Saline ले लिया था. So now we start the session. First of all, I welcome all of you in this 8th Global Rhinoplasty Fellowship Program and in live cadaver dissection program. And I heartfelt thanks to my moderator, especially my mentor, soon Dr. Sandeep On, Dr. Sandeep Uppal, Kapil Agarwal boss, and Dr. Pradeep Goyal. And I also welcome all my fellows. They come from the across world, the different part of the world. So I think I want to just introduce yourself with your name and just with your mic देना इनको. माइक देना. राजवीर माइक देना एक बार. जस्ट सर के सामने इंट्रोडक्शन हो जाएगा. या you just with the name and with your
participants.
Yeah, the participant, they introduce yourself, boss.
Yes.
I'm Dr. Priyanka Rana. I'm a maxillofacial surgeon practicing in Gujarat, Baroda.
Yeah.
Thank you.
I'm Dr. Manaf Abu Shamala from Palestine, ENT surgeon practicing more than 15 years.
Good to see you, man.
Dr. Hani Al-Khalaf, consultant plastic surgery from Saudi Arabia, practicing since more than 5 years.
Yeah.
I'm Devian, ENT surgeon from Chennai, practicing in Australia.
Yes. Thank you.
Good afternoon, sir. Sir, I'm Dr. Girish Sharma. I'm a plastic surgeon practicing in Haryana.
Yeah.
Haryana where?
Sir, in Karnal.
Okay. Nice to see you, man. All the best.
So
I'm Dr. Sudhir from Andhra Pradesh, sir.
okay.
ENT.
Yeah.
Yeah.
I'm Dr. Anand Rajan. I'm a plastic surgeon practicing in Brunei.
Brunei.
Close to Malaysia. Yeah.
Thank you.
Thank you.
So after the introduction of everyone,
Everyone knows the operating surgeon, Dr. Sunil. He is a ENT surgeon and now he is a fellow. Can you hear me?
yes, boss, we hear you.
He is a diplomat board of facial plastic surgeon from USA now. He is a big surgeon, and he will be showing the rhinoplasty dissection on cadaver.
Yeah.
I hope that everyone will be benefited by this.
Thank you so much, boss, your kind words and your blessings. So in the course day 1 we have this cadaver dissection demonstrations, and before to start dissection steps, I want to discuss in the brief then how you start the rhinoplasty practice, and once you start your rhinoplasty practice, then how you improve your rhinoplasty practice. So the first thing then, how you start your rhinoplasty after the post graduation, when you switch your in the rhinoplasty practice, then first you just have a mentor, you have a teacher, you have a guru. Bina guru gyan nahi. That's like you have a teacher. I'm lucky that I have a lot of good mentors, Dr. Sandeep On, Dr. Pradeep Goyal, Kapil Bose, Sandeep, a lot of good mentor. And the second, you read 1 or 2 good books. I think the Rollin Daniel is very good, that the textbook of Rollin Daniel. And the Dean Torumi section manual, that is also a good book. So read 2 or 3 times 1 or 2 books, and then watch the videos, YouTube videos, and then you attend the cadaver dissection course and then the hands-on. So this is the way then you start your rhinoplasty practice. But once you start the rhinoplasty practice, then how you improve your rhinoplasty practice? So there is a certain protocol that you should follow. So ideally there is a 5 step I summarize by which you can improve your rhinoplasty practice. So the step 1, that is the patient selection. your patient selection, that is the most important thing. Your patient, that should be primary motivated, not secondary motivated. And you always remember the focus, the concern of the patient, either this is the cosmetic, either is the functional. If your patient have the functional concern and have the gross deformity, that is good for beginners. If you attempt the patient have a minor deformity, then you have a more chance of the litigations. So patient selection is the important thing. Another important thing, we always focus on the patient selection, but we forget the comfort zone of the surgeon. You always remember the comfort zone of the surgeon. I think it's my advice to my beginner friends. If they start in the initially, if they the easy cases, so once the case result is good, then when the patient is happy, then you build up your confidence. So this is the first step, is the patient selection. And then the second important step, patient analysis. Your patient analysis, that thorough from the outside of the nose to the inside. You complete examine your outer soft tissue envelope, because in my country or in the Asian, we have a thick skin patient. So in the thick skin patient, you definitely affect the things, the prognosis of the surgery, because patient think after the removal of the splint we have a good refined nose, but it's not possible in a thick skin patient. So you complete exam, because when you have a thick skin patient, then definitely you need a lot of work to change the appearance of the nose, but will take time to the final result. So these all things you explain to the patient. And then you also examine the inner framework also thoroughly, just to make the proper diagnosis. You have to know that your patient have in what part of the component, what anatomical deformities. Okay. And the third important thing regarding the interior examination of the nose is also important. I personally examine that some of my plastic colleagues, because they routinely don't have the endoscope in their OPDs. So sometimes they miss some findings, because sometimes if a patient have like the inferior turbinate hypertrophy, posterior septum deviations, or sometimes have the patient have a septal perforations. So these things are important. These all things should be documented. And after the COVID examination, lot of the patient have anosmia. So the history is also important, and all these things documented. So the second step, that is the patient analysis, just to make the proper diagnosis. Now the third step, that is basically just for the your operative steps, your approach and operative steps. And if you jump from one step to another step, that is not good of it. After your examination, your approach should be decided, your operative steps should be decided. After when we start the dissection, then we follow today with certain G steps, 7 golden steps of rhinoplasty. So your operative step, that should be sequential. Okay. Now the fourth step, that is your outcome analysis. So for outcome analysis of your cases, you have the two basic tools. For one, you should have the high quality reproducible patient imaging. Your patient imaging pre-operative and post-operative, that should be perfect. You have to knowledge regarding the studio space, regarding the background, regarding the light, regarding the camera, regarding the which lens you use, and your background in the pre-op and the post-op the same. I usually say there is a lot of young guys, they usually take the photograph from the Android mobiles. That is not good. And the second tool, your operative worksheets. Your operative worksheet, that should be accurate in your own handwriting and at the time of the surgery. So you identify where you did the mistake in earlier case. Okay. This is the fourth step. And the last step, that is the fifth step, that is the critics. This is the important step of the learning. Once you start your own critics, then suppose sometimes when a patient have a crooked nose and after the surgery the patient is happy, but you are not happy. This is the critics. But for the critics, you put aside your ego and then you realize this thing, then you never become a master in this rhinoplasty, because it's the totally different surgery in all of the facial plastic surgery. Learning is the never ending. So in rhinoplasty pathway, once you start to critics, then how you improve your critics? Again, go back. You go to your mentor. You just read books, watch the videos, and attend the cadaver course and attend the hands-on. So this is the rhinoplasty learning cycle. So basically, if you follow these steps and the finally in the rhinoplasty, there is no standard rhinoplasty. Each operation is unique, and according to the patient deformity and according to the comfort zone of the surgeon, just achieve the desired goal of the patient, we decide. So this is the learning pathway of the rhinoplasty. So now we come to the we have a separate lecture of the patient imaging day after tomorrow. So then we cover the entire which lens imaging. So okay. So now we start our steps. So just to make the simplification for my beginner friends, the rhinoplasty steps, in the open rhinoplasty, I create the 7 golden steps. Okay. And in this 7 golden step, the step first, second and last are the almost same in each patient, like infiltration, like the opening of the nose, and like the closing of the nose. They are the almost same in all patients, And the mid step, like the 4th, 5th and 6th, like septum modification, like the bony pyramid modification, like the MIDVAULT modification, like the tip part modification. They are according to the present anatomical deformity. We have the different. And we have these G steps of golden rhinoplasty. Just for learning, I create these 7 steps. So one by one steps, we just proceed in this cadaver dissection program. So first, the infiltration. The first step is the infiltration. So for the infiltration, for at-chromatic dissections, we have the good infiltration. I usually use this 2% xylocaine in 1:1 leg ratio. I usually use this 5 ml syringe for the infiltrations, and this 26 gauge needle in 1.5 inch needle. Okay, and then learning infiltrations, like sometimes we confuse how we start the infiltration. So once you develop in like the stepwise manner, then it's easy. So the infiltration we can just divide in the 5 steps. Okay, the first step, we infiltrate in the septum. Okay, along the site of the incision. So we infiltrate in the septum like in this way, in the mucoperichondrium. But when we infiltrate, then the important thing, rather than blanching, we have the ballooning. This is the cadaver, so little bit difficult, but so rather than blanching, then you have the ballooning, because ballooning help you in your mucoperichondrium deglowing. So look that when you have a ballooning, then it help your dissection in the multiple prick. Ideally, the should infiltrate along of the incision. Either you use the Killian's incision or either you use the hemitransfixation incision. Which incision you use, it's depend on what type of a deformity. दूसरी वाली needle देना छोटी वाली. What type of the deformity patient. If suppose your patient have a caudal septum deviations, then you use the hemitransfixation incision from the anterior septal angle to the posterior septal angle on most prominent caudal part of the septum. But if your patient have a posterior septum pathology, then your incision is the Killian's incision, that is 1 centimeter behind the vestibular and this nasal mucosa. So this is the first step of the infiltration. And some renowned surgeon like Dr. Hossam and so many surgeons, they use only infiltration in the along the site of the incision, but I personally advise for my beginner friend, I think it is a better if you infiltrate on entire of the septum, anterior and the posterior, because this is mucopericordium is little bit dry in this cadaver. But so this is the balloon, okay? This is the first step. Now the second step of the infiltration, transcolumella incision. So look that how you infiltrate. You hold your tip lobule between the index finger and thumb, and from the tip defining point to the anterior nasal spine like this. From the tip defining point to the anterior nasal spine like this. And then again between the tip defining point like this, and in this vestibular mucosa also, vestibular skin like this. So this is the second step of the infiltration, and after the infiltration by your index finger and thumb, you massage it for the disperse of your local infiltration, okay? So this is the second step of the infiltration for the transcolumella incision between the tip defining point to the anterior spine, okay? And if you,
Dr. Sunil,
yes,
somebody is asking actually
yeah,
that you have infiltrated the tape from above
yeah,
in vertical fashion,
yes,
and then columella.
yes,
You have not done any horizontal infiltration from in front.
no, I usually use
From the
like
side
this.
only. So they are asking that why don't you infiltrate the columella from this side,
Yeah,
looking at the 90-degree angle?
yeah,
Is there any
like
problem in
this,
that?
like this.
Like this, yeah, like this.
Yeah, you can infiltrate definitely.
No, you should not infiltrate like that. Inadvertently, your needle may go into one of the columnar artery,
Yeah.
and sometime it goes in the artery, and later on you may have the necrosis of columella. So always go from above and infiltrate it, so that there is less chances of infiltrating into the artery itself.
Yeah, perfect. You are right, boss. And so basically in my course, I develop the certain basic steps. I repeat again and again. So my the techniques use according to your convenience, and you are absolutely perfect. So this is the second step. Now third step, mic check करना उसको बोलना आवाज जा रही है बार-बार शायद. So the third step of the infiltration, that is for the marginal incision. So for the marginal incision, when you infiltrate, then you need this wide double prong retractor, and then like this, and you invert by your skin. So this is your margin of the caudal margin of your lateral crus. So along the caudal margin of the lateral crus, you infiltrate like this, and in a multiple manner, and like this in this soft triangle area also. The same. So you infiltrate around the 0.1 or 2 but too much. So this is the third step of the infiltrations, and it's simple. You can palpate your margin of lateral, handle of the knife like this way. Just you invert, and the role of this finger is important. You invert like this, and you can palpate there's some rigid structure. So this is the margin of the lateral crus, and sometimes when margin of the lateral crus is so, then basically the hairy and non-hairy junctions you can infiltrate. So this the dorsum degloving. Okay, so the important thing, exact the site of the infiltration where you insert your needle. So look that, then you identify the junction between the upper lateral cartilage and the lower lateral cartilage. So this is my upper lateral cartilage, this is my lower lateral cartilage. So once I prick this needle like this, and then I hold this skin, because sometimes if you go like this, then the needle comes out through the skin. So you hold this one and go just like this on the paramedian positions, the upper limit, that is the intercanthal line. So in this way, then you infiltrate on the both side, right side and the left side. You never infiltrate exact on the midline. Like Dr. Pon always said that when you infiltrate on exact on the midline, then you disturb your contour irregularities. हाँ सो उसको चेक कराओ, देयर इज सम, चेक करो फिर मेरे को बताओ, चेक करो. There is some, they check some technically my sound. So this is basically the fourth step. So first step, that is the infiltration in the septum, okay, along the site of the incision. This is the first step. And the second step, just for the transcolumellar incision, from the tip defining point to the like the antenasal spine. And then the third step for the marginal incision, okay, along the caudal margin of the lateral crus. And then the fourth step for the dorsal deglobing. Now the fifth step of the infiltration for the lateral nasal wall for the osteotomy. So for the fifth step of the infiltration, the landmark, that is the inferior turbinate. Okay, you identify this is your anterior end of the inferior turbinate. So just lateral to the anterior end of the inferior turbinate, you pass this needle, and look that you can appreciate my needle. This is my needle. So we infiltrate along the lateral nasal wall on both sides. So this is important thing where you insert your needle, your site of the infiltration, that is the important. Usually this step is skipped because at the time of the osteotomy, usually we infiltrate, because just to maintain the effect of local infiltration. उनको देखना मेरी साउंड ठीक है क्या, अभी कैरी ऑन करेंगे, एक बार बताना ऑडियो विजुअल वाले से. हैं?
Right. Hello, people. They are not able to hear you.
There is some problem, so they correct it, boss. इसलिए मैं रुका हूँ थोड़ा सा.
I can hear you, but few people are not able to.
Yeah. So boss, any your comment regarding the infiltration, just for beginner friends?
You are absolutely right. Absolutely right.
Okay. So because everything, when you learn, when you develop the habit now, then you develop the step by step manner. When you follow the certain steps, then you are never wrong. So you just make a rule, like you infiltrate in the septum for the transcolumellar, because the incision are the same in open rhinoplasty, transcolumellar and marginal incision. So and you develop, and after the infiltration, I usually use the cold saline also, because in the cold saline there is no harmful effect if you inject axis also, but it help in the hemostasis and in the mucopericardium deglobing also. So I usually infiltrate the cold saline also. Dr. Sandeep boss is there?
Hi Sunil.
I was any comment regarding the infiltration, boss, for our beginner friends?
Yes, I mean I think I agree with most of the things that you have mentioned, Sunil.
Yeah.
The infiltration has to be done properly so that you can get a bloodless or nearly bloodless field.
Yes, yes. Now, after the infiltration, this is the first basic G step of rhinoplasty. Now, the second.
Good afternoon, Suri. I'm here, Dr. Goel.
Yeah.
Good afternoon. Good afternoon. Along with infiltration, that anesthetist should take care of blood pressure also, or better hemostasis, better visualization of tissues.
Dr. Pradeep Goel sir is my mentor, and I am lucky that I have like mentor sir, Dr. Goel sir, and is just head of department of the plastic surgery SMS Medical College, just retired. Sir, you joined late, I think, little bit. So the second G step of rhinoplasty, that is the exposure. You know, the exposure is the very important, like not in rhinoplasty, in each and every surgery. Okay, so for the exposure in open rhinoplasty, usually we use two incision. One is marginal incision and one is the transcolumella incision, or you can say then both marginal incision we join by transcolumella incision. In lot of conferences and workshop where I do this cadaver dissections and the courses, all my beginner friends, they have some packed questions. So the three questions they usually ask, they bias about them. The first, then which incision they use first? Either they use the transcolumella or the marginal incision. Question 1. Second, they are biased, then which type of the incision, sir, is good? Either the inverted V, the stair step. And the third common question they ask, what is the exact site of the incision where we put the incision? So we just clear first these query, the three questions. Number 1, regarding the sequence of like the incision, either you use the transcolumella incision or the marginal incision, it's hardly matter. You know, some renowned surgeon, they use first the marginal incision and some use the transcolumella. Initially when I start my practice, I use marginal incision first and then transcolumella. But now I first use the transcolumella incision and then the marginal incision. Why? Because once I lift up my transcolumella flap, the rest of the incision is under my vision. Okay, because once you do the more and more cases, then you develop your own techniques. Okay, so the question 1 is the clear. Now the second, there is different type of the incision, like the inverted V, stair step, but mostly the two type of the incision usually we use. One is the stair step incision and another is the inverted V transcolumella incision. I usually use the inverted V. I am not fond of the stair step incision. The problem in the stair step incision, because one limb marker dena, one limb of the stair step, that's just nearby to this soft triangle area. So sometimes at the time of the healing, the patient develop a asymmetrical scar. Okay, but again it's a matter of experience. Still there's some good renowned surgeon, they use the stair step, but personally I am not use. I usually use the inverted V incision. Behind all these, when we use the incision, we never use the straight incision. We use the incision in the zigzag manner. Why? Because when we lengthening the skin, and then you have a less chance of the scar. Okay, so we use in the inverted V fashion. The third important thing, that is the site of the incision. This is the most important thing. The site of the incision. Usually the site of the incision, that is the mid-nervous part of the columella, we usually use. Now the question, why is the mid-nervous part? Why we note the above and the below? Because the mid-nervous part of the columella, the skin, that is the more approximate with the margin of the medial crust. So the skin have a good support. At the time of the healing, you have the less chance of the scar contracture. Okay, and in certain circumstances, like if you have a binder syndrome, then for lengthening of your transcolumella flap, then you use the incision is the different in the low columella or in the 2I manner. Or sometimes if you want a significant deep projection of the nose, then your incision little bit higher. So after the deep projection, that automatically comes down. Otherwise, the mid-nervous part of the columella, that is the ideal site of the incision. Okay. Now, how you decide the mid-nervous part of the columella? How you decide? The usually mistake done by the beginners, they mark like from this to this. This is the wrong method. The ideal, the right method, this is the apex of the nostril. So from this to this, now you mark the mid part. Okay, so like this, because you develop the marking is a good habit. Ideally, the distance between two vertical limb is the 3 mm, and the angle between this horizontal, that is the 60 degree, and then few millimeter, 1 or 2 millimeter behind, like this. So now after the marking, for making the incision, I usually use this 11 blade. But how you use your knife, that is the important thing. So just you hold your tip lobule between the index finger and thumb, and not like this and not like this. This should be straight, okay? And you hold your knife just perpendicular to your skin, like this, and again on this side like this. Okay, now I use the 15 number blade. So for 15 number blade, now look that there are some small things, like if you make like this, then you have the chance of the damage of the ala margin. So I think it's the better if you develop your habit from the lateral to medial along your marking. Okay, now on this side, and on same on this side. So just you complete your incision on both sides. Now the next step, you just need a sharp scissor. This is the sharp scissor. So again you just, but the important thing, you always hold it firmly. So counter traction is important. You pass this needle from this side to this side. But remember, if you feel the resistance, you never is forcefully. You go from the contralateral side. You go from the contralateral side. Otherwise, you create the false passage. Okay? And now, then you have the support of the scissor and you complete this incision. Dr. Pawn is there. I think Dr. Sandeep is Pawn. Sandeep, well, I think he's still. So
he has not joined.
Yeah, it's not joined. Say they have some urgent work. So now we complete this incision. Sometimes during this maneuver, we have damaged the margin of the medial crust. So if you injury some margin of the medial crust, you never panic. Okay, you try the habit. There should be no injury, but if you develop, then you can repair. So now the further after the complete incision, the two instruments. बोलना मेरी बार. So you need the instrument. One is the single hook and one is the small wide double prong retractor. So because sometimes after the incision, when you make, we have some columellar vessels here. Because if you see the blood supply of the nose, then the superior labial artery and the angular artery, that is the branches of the facial artery. So from the facial artery system, some branches of the columellar vessels, that are the superior, they ooze if you have the, okay. So now the counter traction is important, like this. And then again you need a sharp scissor. So first you assure your margin of your medial crust. How? Just you hold your scissor just like a pen holding position, and just like this. So this side of the lateral crust. This is my margin of the right side of the lateral crust. You appreciate it? And on another side, on this side, this is my margin of the left side of the margin of the medial crust. So first you secure your margin of the medial crust. Now for further dissections, once you identify the margin of the medial crust, then you just spread it and cut it like this. Spread it and cut it. And you never take the big chunk of the tissue, because if you just take the big thing, then if you have the injury, the load. So just like this, spread it and cut it spread it and the cut it along the margin of the lateral crust.
Sunil, your video is very slow. It's freezing up.
Video is very slow. अरे audio visual को बोलना. दूसरी सीजर देना, शार्प वाली, अच्छी वाली चाहिए. शार्प सीजर चाहिए मेरे को. वीडियो चेक करना. हो गया सही? Now is fine, boss?
Yes, better now. Thank you.
Okay. So, you just along your margin of the lateral crust. शार्प सीजर देना मेरे को दूसरी वाली, थोड़ा सा इसमें एडहेरेंट है, ये लगाओ. So counter traction is important like this. Yes. Now on this side same. Yes, ये सीजर देना मेरे को. So along the margin of the lateral crust and small wide double prong, small one, still this small one, ये वाला. So by your assistant just like this, then this is your site of this one, this is the margin of the lateral crust. Okay, this one, this is the ideal site. So
recording in progress.
Be safe in this soft triangle area, because if you have a minor injury in the soft triangle area, then you create a notching later and it's very difficult to treat. Yes, there is little bit injury. Now, वो देना, बड़ा वाला देना. So now after that you need, after the complete your incision, just for further degloving of your mucopericondial this flap. Yes. So now for soft tissue this degloving, we expose the both sides of the lateral crust. The two things are important. One is the plane of the dissection, okay, and another is the, इसको hold करना, ये ना. The lateral limit of your marginal incision is also important. Then everyone asks, then what is my lateral limit? So at least you should expose 2/3 of your margin of the lateral crust, okay. And the margin, basically the plane of the dissection, that is the important. So how you get the plane of the dissection? Once you find the plane little bit on the lateral crust, then on this side also. My usually plane of the dissection that is the suprapericondial, because all Western book they mention the subpericondial, the incision. Subpericondial plane. In India we have the thick skin patient, so if you have the suprapericondial, that is the good, otherwise you weak your lateral crust. So then I use this Kakir periosteum elevator for getting the plane like this. There is some fibrosis in this patient. Yes, cadaver, go. So you use the classically 3-point traction technique. One small wide double prong retractor like this, okay, and another वहाँ पे लगाओ. So the plane of your dissection, that is the suprapericondial. So you expose your lateral crust on the one side like this. Now this dermocartilaginous structure, that is the pitangui ligament, that have the transverse fibers and some the vertical fibers, basically that connect this cephalic portion of the lateral crus and attachment with vertical fiber with this soft tissue envelope. So it's a type of a dermocartilaginous ligament. Yeah. So, Dr. Sandeep, what is your opinion regarding the preservation of the this pitangui ligament?
Sunil, I try to preserve it where possible. If not, then I identify it and mark it with a suture on both the sides.
Yes.
And cut it, and then towards the end of surgery, I will try to reconstruct it again.
Yeah. But in the thick skin patient, I think there is a I think not so useful in the supratip break concept. But in your patient, I think in the Singapore the patient have not the thick skin patient, so I think it's okay.
Yeah, I think it's not only about creating the supratip break, but also to prevent soft tissue polybeak later on. Sometimes because of bunching in the hip area, you can get that if you don't reconstruct this structure later on.
Yeah.
I think it helps from that point of view.
Yeah, perfect. So basically it's one of a minor tip support mechanism also. Then later we discuss regarding the tip. So after the exposure of the both of the lateral crus, then we degloving this mid-vault like this. You can use the seizure. I usually use this Kakir periosteum elevator, and you just hug with your this mid-vault, and then you expose your bony vault. Now again the question that what is your upper limit of the dissection, that is the intercanthal line, and on either side at least you should expose around the 1 centimeter on either side, because definitely when you have a crooked nose, then you complete exposure of your inner framework just for modification is important. So now we expose the lower lateral cartilage, then the mid-vault upper lateral and the bony pyramid. So now we further move for the septum exposure. I usually use this basically it's a self-retaining dorsal retractor. It's a very good instrument of the Najim circus, developed by the Najim circus. Self-retaining, so no need to hold this. Okay. Otherwise, one person may hold this by this off-ridge retractor. So now the further step, because now we want to expose your septum. So what is your further step? You need these Takahashi, these forceps. Okay. So you hold ऐसी forceps नहीं हो. So like this. You just give the counter tractions first, okay, just on the anterior-inferior directions, and then you need this sharp seizure, and then spread it and cut it. Like this is the interdomal ligament, okay. Just cut it. मेरी headlight की battery change करना. And again, you spread it and cut it, but in your eyes, in your mind, you have a framing that what you want to identify. We want to identify the anterior septal angle area. Okay, so just spread it and little bit. Automatically, you find something. Look that this is your septum. Okay, this is your septum. So now you change how you hold like this. यही रहो यहाँ पे. You hold like this, ask your assistant, इधर से पकड़ो. Because earlier we hold like this, now we hold like this, just nearer to this one. Now the things are changed. So everything is important. Again, we separate this little bit and spread it and cut it. So we expose our septum. Now, for expose of your mucoperichondrium, deglowing your mucopericardium. Now I usually use this seizure just as a pen holding position. You can use the periosteum.
Please ask this cameraman to focus the light. Actually, too much of light is there on that.
अच्छा
Clear is there, clear.
देखना, चेंज करो थोड़ा सा, आप थोड़ा सा इसको जूम बढ़ाओ आप दीपक जी, आप पास में लो एक बार। बस अभी कैसे है?
अभी सेंटर आउट हो गया थोड़ा। Now it's okay. All right.
So you hold this seizure just as a pen holding positions, and then just you separate this mucopericardium like this, and remember then this is the one of the most difficult step in the rhinoplasty, especially when you have sometimes a beginner and when you have sometimes a crooked nose, when you have a post-septoplastic cases or in a pediatric rhinoplasty cases. So if you find to get the plane on one side, then you never panic. If you sometimes you have a injury in the mucopericardium, so you change your directions, you go on another side, because in the rhinoplasty just to keep the patience is important. But another important thing, if you hold like from this and if you do work, that the things are different. But if you hold from the near one, look that you develop the things, you develop a net. So this net that is good for you. So you just separate this mucopericardium just like. You can use the periosteum elevator also. And if you are in the wrong plane, then you just keep the patience and just to make a scratch by end of the 15 number blades, and then you can. But if you are in the wrong plane, then you have a lot of bleeding. Wherever you have a bleeding, then something is going on the wrong. Okay. Then on another side, छोड़ो इसको. Again, I like this. Just you hold. Now this is the same.
Santadev has joined.
Hello. Sir, good afternoon.
Afternoon.
Hi, good morning. Sorry.
We are waiting for you.
My apologies. I had a very late night last night, so I apologize. It's early in the morning here, and I did put my alarm on and I slept right through it.
Okay. Good. Thank you, sir, and welcome, sir.
Morning.
How are you?
Morning, everyone. Dr. Satyadeep, good morning. I'm Dr. Goel.
Hi, good morning. How are you, Doctor?
I'm good. I just want to have a comment. For pericardial dissection, I use 15 number of blade.
Yeah.
And the back side of that.
Yeah.
So that's again very good thing. You don't injure anything, and it is.
Yeah, you use like, sir. Yeah, like this.
Yes.
Yeah.
That's
That
right.
also learn the technique also. But I just make that easy the things for our participants. So that's why I use. Otherwise, once you develop the habit, then you can use either the 15 number, you can use the seizure, and you can use. So now you follow a certain sequence when you deglowing your mucopericardium. You know, first you deglowing on the anterior superior part, and then you just on the posterior inferior part, and then the posterior superior, and the last on the anterior inferior. Why? Because on the anterior inferior we have the densely mucoperiosteal attachment. So if you develop the sequential your work, then you have the less complications. Give me the periosteum elevator. And another important thing on this stage, now for my beginner friend, then for getting the more exposure, I think is better you just separate the upper lateral and the septum. But before to separate the upper lateral and the septum, you just assure your mucopericardium in internal nasal wall area, you deglowing it completely. Look that you can appreciate my periosteum elevator. So you first deglowing this mucopericardium in this internal nasal wall area before to separate the periosteum, separate the upper lateral and the septum. So like in this way, on this side also, you can appreciate my periosteum elevator. Okay. Now you separate the upper lateral and the septum for getting the more exposure. इसको पकड़ो. So this is my right side of the upper lateral. Now I separate it like this and like this. But if you separate it without separating this mucopericordium, you have a lot of the bleed, and later you develop the synechia in this area, and consequently you develop the functional problem. So I separate. Now you have a lot of space just for work, for exposure. Okay, give me the periosteum elevator. I usually use this storage periosteum elevator, that is the one side is sharp and another side little bit blunt. इसको पकड़ो मुकेश, इसको पकड़ो. And you can use this self-retaining lateral crura retractor like this. So you have everything is under your exposure. Okay. Now you separate this mucopericordium. Is so simple. First, just in the posterior inferior, and everything is in front of your vision. And once you separate on the both sides, look that, then on the posterior superior region. Now on this side, septum work is the key step in the rhinoplasty. This patient on this side have some infection, cadaver have the some abscess or something on the, so just I follow the same sequence on this side also. So I complete separate, and now on anteriorly on this part also. Yes. In this inferior part of the caudal septum, this have this infection. Yes. So now this step, the exposure is complete. We expose the lower lateral cartilage, we expose the midvault upper lateral cartilage, and we expose the bony pyramid. Okay, so we just discuss little bit the interior anatomy and the internal relationship, then we follow the next step. Look that this is the septum. Okay, because the septum just have the three part. One is the bony septum, that is the cartilaginous septum, and just behind this medial crest we have the membranous septum. Okay, this septum, this superior border, that is the dorsal part of the septum. This is the caudal part of the septum. Okay, double look laga na bada. So the angle between this dorsal and caudal part, this is the anterior septal angle area. Okay, we have the two more septal angle also, but clinically this anterior septal angle is important. Another, the angle between this posterior part of the septum and this caudal part of the septum, this is the posterior septal angle area, and this is the mid septal angle area. Okay, now this is the right side of the upper lateral, this is the left side of the upper lateral. Okay, and this upper lateral, ऐसे करना है इसको, this upper lateral is a basically just the T-sept cartilage. Okay, that have the medially, this is the medial margin of this upper lateral, and one is the lateral margin of the upper lateral. Okay, they both end of the medial and the lateral end is important. Medial end of this upper lateral cartilage, they attach with the septum at a specific 10 to 50 degree angle, that we say the internasal wall area. Okay, and the lateral most part of this upper lateral, that doesn't have any sound attachment. This attaches only wedge of a triangular bone in the lower part of the piriform aperture, that we call the Webster triangle area. Okay, and one is the superior end, one is the inferior end of this upper lateral cartilage. So the superior end of this upper lateral, this superior end of the upper lateral cartilage that attached with the distal part of the nasal bone, that is the keystone area. That is the keystone area. So in this center part, the overlapping of this distal part of the nasal bone and this proximal part of the upper lateral cartilage is maximum. That is around 9 mm. But if you go on the lateral, in the peripheral keystone area, that is overlapping is reduced. So this upper lateral cartilage get maximum support from this central keystone area. That's why we always maintain integrity of this area of the keystone, central keystone area. Okay? And if you come on the lower down, thoda sa straight come karo. If you come on the lower down, then double forceps do. The lower end of this upper lateral cartilage, marker bhi dena, and the upper part of this lateral crus, they have a overlapping. What is the name of that one? Scroll area. That is the scroll area. The scroll area that overlapping around the 15 mm. This one. So this is the scroll area. What is the significance of the scroll area? This is the scroll area. Because it is one of a major tip support mechanism, because the tip have the three important tip support mechanism. One is the size, shape and resilience. This is the resilience. This is the resilience of the entire LR cartilage. Second, that is the scroll area. And third is the attachment of the caudal part of the septum with medial crus. So tip have these three major tip support mechanism. So this is the scroll area. This is the scroll area. We always preserve the scroll area. Okay. Now, if we come the anatomy of this after the septum and this upper lateral cartilage, this is a pair of LR cartilage. Okay. So this one pair of LR cartilage, this forms a tripod. Okay. This is the central limb of the tripod and this is the lateral limb of the tripod. Okay. So this LR cartilage, have the three part. You visible the three part? One is the medial most part, this one. One is the lateral most part, this one. And the part connecting these lateral most and the medial most part, this one. So this is the medial crus, this is the lateral crus, and the part connect, that is the intermediate crus or the middle crus. Each part have their own significance, and we deal according to the present anatomical deformities. Okay. This first part, medial most part, that is the medial crus. This medial crus is basically a principal component of this columella. Okay. And this is responsible for the mainly the projection of the tip. And this have the two part. One is the foot plate part. This part is the foot plate part. This part is the foot plate part. Okay. And this part is the columella part. This foot plate is basically rest on the anterior nasal spine. We have a fatty tissue here. Sometimes after the infections or injury or after the surgery, if the fatty tissue may get reabsorbed, the patient develop the droopy. And we never disturb this foot plate part because or incision, that's why we always keep above, because we have a major tip support mechanism. Okay. And then the second part, that is the intermediate crus. Again, the intermediate crus have the two part. This angled part, that is the dome part, anterior part, that is the dome part, and this is the lobular part, where the medial crus start to diverge, where we start the lobular part. So this lobular part is basically responsible for the infratip lobule. Okay. And this part, dome part, that is basically for the width of the tip and the definition of the tip. It's very important part. This is the smallest part of the LR cartilage, but is mainly responsible for the angle and the shape and width of the tip. Okay. And then the third part, this is the lateral crus. This is the widest part of the LR cartilage. Okay. And this part is maximal responsible for giving the volume of the tip. Okay. And these have the two margin. This is the cephalic margin that we already discussed, that form the scroll area, and the caudal margin of this lateral crest is also important, because this caudal part is responsible. Basically, we usually use as a landmark for the marginal incision, for the infiltration. Okay, and this caudal margin of the lateral crest, that also give the support anterior half of the basically this ala margin. Okay, so this all about the anatomy of this upper lateral, lower lateral and the septum. But there is certain interrelationship of this anatomy. There is a relationship between this dome and this anterior septal angle. Okay, ideally the dome, this dome area, that is around the 5 mm anterior and 1 centimeter caudal to this anterior septal angle area. That's why we usually have a supratip break, because this dome area is little bit higher and anterior. That's why we have the supratip break. Another important relation, the relation between this caudal part of the septum and between this medial crust. Ideally, around the 2 to 4 mm protruding this this caudal part of the septum between this medial crust. Okay, for a normal columella show. What is the columella show? The one is the normal columella show. What is the normal columella show? Ideally, there is a relationship between the ala margin and this columella. Around the columella show is a 4 mm. This part is the 4 mm anterior. Why? Because this caudal part of the septum, that around the 2 mm between this medial crust. If more than this, then we have a hanging columella. Less than this, we have the retracted columella. Okay, so these are the relationship between interrelationship, and the distance between this dome area, that is also fixed. That is around the 6 to 8 mm in the female patient, but 8 to 10 mm in a male patient. So you have to know about the normal anatomy, about the normal relationship between this area. So now we complete all the exposure part. Now we move our third G step, third golden step of open rhinoplasty, that is the septum modifications. So in septum modification, first you go like initially and the time of the start we dissection, that I mentioned what is the concern of your patient. If your concern of the patient is purely cosmetic, no functional problem, then just you harvest the septal cartilage. Okay, but if your patient concern is functional, then for functional correction we just go either the septoplasty, either the septal reconstruction, either the septum repositions. We all things are the mentioned. So before to modification of the septum, first you analyze your septum. If you think your patient have the functional problem, okay, then before to create the L strut, first if your septum have axis dorsal part, वो लगा ना self retaining, if your dorsum you have the axis dorsal part or axis caudal part, you trim it. But the usual common mistake by my beginner friends, they first harvest the septal cartilage, they create the L strut, and after they trim the axis part, then they weak their L strut. Okay, so first you analyze. Suppose in this patient 15 number blade dena. Suppose in this patient, look, we have this axis part, because this patient have a caudal, this cadaver have a caudal septum deviation, so we have this axis part. So वो लगाना यहाँ पे, we first excise the axis part. So we excise this axis part of the septum. Because when we excise this axis part of the septum, that he allow the come to in the midline, and if you suppose if you have the axis part of this one, then you just excise, like you hold like this and then pakadna in this manner. Okay, so first you judge that whatever amount you have the axis, you excise like this. Now you preserve your L strut. So this is your septal cartilage, and you for create the L strut marker dena, first you preserve at least 1.5 centimeter dorsal and 1.5 centimeter anterior. Like you mark like this, and then note the acute angle like this. Okay, and then you just use the your knife, just you hold this one like you appreciate it. So now just you make an incision here, yes, and then just you rotate it, then note the acute angle. So now we separate from the superiorly and from the anterior part of the septum, and now just you need this speculum. Sandeep sir, you want to add something regarding the IL strut? Sandeep sir?
Yeah, I'm here. No, I think every year I watch you do this, and every year it's great. Yeah, everything I've ever taught you seems to be you're teaching everyone else. So no, that's great. Yeah, I mean, I'd agree that the one thing you've got to be careful about though when you're leaving the L strut is making sure that you judge, because if you've got a big hump and you leave 1 centimeter and then you're taking away 3-4 millimeters, then you're going to end up with inadequate support there. So you must make sure that you leave enough cartilage. And if you're not sure, do all the dehumping first, and then take the cartilage you need for grafting afterwards. So often I will leave this till a bit later on in the dissection if you're not sure how much you're going to remove from, because you want to make sure that you leave enough support in the L strut, because that's the problem. And like you said, beginners will sometimes take away too much to begin with, and then find that they're stuck then, because if they're having to remove quite a lot of cartilage at the dorsum, and then they've not left enough behind. But other than that, no, I'd agree with everything you're saying.
Yes, sir, perfect. So first you just judge, and like sir says, first you judge according to your case. If you have axis, then you exercise the axis bump, and then now I separate the this part of the septum from superiorly, anteriorly. Now from the posteriorly, I usually use this sharp instrument. Just some people use a Bellinger knife also, but I by this multiple perforations, like I separate from the PP, perpendicular plate of the ethmoid. You can appreciate it. Look that, and then you like this. Then first you check either you separate or not completely cartilage holding forceps. So first you check. If you feel that little bit attachment, still you never pull it. If you pull it, then entire septum is come out. Okay. Then you 15 number bleed. So just we cut it a little bit, and then again we remove this one. Yes, sir.
How do we cut the bony septum?
But usually I use this sharp instrument. Look that just I separate from the attachment from the perpendicular plate by the multiple perforation, just like this, and you can use like the Bellinger knife also. So this is the way. Then I usually separate from the bony septum this septal cartilage, and
I think Dr. Kapil was asking about actually taking out bony septum. If you need to take out bony septum itself,
yes.
How would you do that, Sunil? How would you do that?
Yeah. So first, I just remove this my septal cartilage, and then if my bony part of the septum is deviated, okay, and then there are two things. First thing, if there is a small deviation, then I fracture it and medialize it, and if on the other hand, if you have a gross bony spur, then I remove that spur. So then give me the lux forceps. So then you expose your both sides, degloving your mucopericardium, and then if you have a bony spur, then you just rotate it but after the rotation you again rotate in the midline and then you remove it. But if you not rotate it in the midline, then you damage your mucopericardium, you develop the septal perforations. So this is the way then you can deal, but it's depend, then it's not, because this is a common question beginner my friends, then is there necessary to remove the bony part of the septum also? So it's depend what your patient have a anatomical deformity. If only the deviation, you fracture it and allow in the midline. And but obviously if you have a bump, if you have a spur, then you remove it.
I think Dr. Kapil may be asking because if you want to use a bony graft as well. So yes, you're right in terms of you may not need to remove it for functional purposes, but if sometimes you want to use a perpendicular plate of the ethmoid graft, or sometimes you want to keep the attached, so you get a composite type graft, so you leave the bone attached to the cartilage, then I will tend to use a turbinectomy scissor, cut at the top end. The most important the most important thing is for anyone out there is not just to twist the bone in the perpendicular plate of the ethmoid, because it can be attached right up onto the skull base area, and if you just twist without cutting, you do risk CSF leaks. So I think you always cut. We're using whatever instruments. Some people use piezo. I tend to use a turbinectomy scissor just right up at the skull base area, and that way you've created a controlled fracture effectively in that region, and then you can remove the bone by just gently mobilizing what's left of the bone underneath, and then you can get a composite bony cartilaginous graft, or you can just take a bone graft out alone if you want to just take the cartilage and the bone separately. But I think that's what you were asking. Is that right, Dr. Kapil?
Yes. Yeah, you explained very well, and it actually serves both the purposes. You can get the graft as well as any deviation or something is there, it comes out.
Yes, you are perfect.
And it will not create any cribriform texture, so there won't be any leak.
Yeah, I mean, there's a lot of controversy whether you need to remove posterior bony spurs, because, of course, most blockage occurs in the caudal aspect of the nose, not posteriorly. So whether or not removing a bony spur makes any difference to the function is controversial. But having said that, when as we all have done, particularly those of us who are ENT trained, you do a septoplasty and you leave a bony bit behind, and then the patient comes back with blockage, then you're always questioning, should I have removed a bit of bone at the back, and is that why they're blocked? So I tend to remove it anyway, just to make me feel better, if not necessarily there's good evidence that it makes any difference.
Yes, sir. So now after the remove,
Dr. Sunil, I will take your leave for just for half an hour. I have to attend one meeting and will come back soon.
Yeah, it's okay, boss. Okay.
Thank you very much.
So now after the harvesting the septal cartilage, this is our AL stud, this is the dorsal part of the AL stud, this is the caudal part of the AL stud. So look that this is the anterior septal angle, this is the posterior septal angle. So this is the part of the septum that is the deviated, because itself the deviated part that effect the push effect on the septum. Okay, so we axis part of the septum we remove. Give me the scissor dena, right dena. So this is the axis part of the septum. Now look that the septum is midline. Look that we remove the axis part of the septum. Okay, so now for the reconstruction of the septum, suppose this caudal part of the septum is earlier like this. This caudal part of the septum is deviated on the one side. If your caudal part of the septum is already in the midline at the anterior nasal spine, there is no need to do anything. But if your caudal part of the septum is deviated, then you after complete removal axis part, then again you refix it. You reposition in the midline for 0 PDS. So there are the different method to fixation of this caudal part. Mostly people use a Linderman burr just to make a hole in the anterior nasal spine, but that is too difficult for my beginner friends, and because in Caucasian patient we have a big long antenasal spine, then easy to make the hole, but in our Asian patient we have very small anterior this nasal spine. So this is a very good methods that I learned from my mentor Dr. Sandeep Paun. That is a very easy methods for my beginners just to fix. You can fix it like with the mucoperiosteums by this 4-OPDS suture. I usually use the 4-OPDS suture. So I pass it from the mucoperiosteum from the one side and then again from this like this. So this is the simple method because we just fix it with the anterior nasal spine in mucoperiosteum.
Dear Sunil.
Yes, Dr. Hakim, how are you?
I'm fine, thank you. My greeting to all, especially our teachers monitoring this session. Dear, when you suture the posterior caudal angle to the spine, will you put the septum straight on the level of the spine, or the caudal part you make it little bit anterior to the spine, 1 or 2 millimeter?
Not too much anterior, exact on the anterior nasal spine. Not too much anterior.
Because normally I think it is little bit anterior to the spine. Am I right, Dr. Sandeep?
Yes, it probably is true. That's probably true that the caudal border just sits, or it's not actually the caudal border. The posterior septal angle, by definition, it's in the anterior nasal spine. But there is a little portion that comes more anterior to it. So when you're actually attaching, I mean, there's two things about that attachment. One, which Sunil showed, you put it through the periosteum, but Sunil, you should show that maneuver where I pick the skull up, pick the whole head up using that stitch, because the most important thing is that stitch is onto the periosteum. It's very easy to put it just through soft tissue.
This is very strong. Look that.
So if you see this, it needs to be literally. You need to be able to lift the skull up.
Look that.
Using that stitch.
So it's a strong attachment.
Yeah, it has to be a strong attachment. In other words, it has to be through the mucoperiosteum. So if you look at the current, Hakim, if you look at where Sunil has done his, there's a little portion there that's sitting forward, 1 millimeter or 2 forward, like you said. But actually what it is that's the part of the caudal septum that's coming forward in front of the anterior nasal spine. But the actual posterior septal angle sits in the anterior nasal spine, and then there's a little bit which comes forward 1 millimeter or 2 in front of it. So that's the bit I think you're thinking about. So you don't necessarily attach it more anterior. It will automatically come a little bit more anterior if you put it in the correct place. Now, sometimes you don't want that. Sometimes you want to push the cartilage back or pull the cartilage forward even. You can even pull the cartilage forward if you want to do like a tonguing groove, but you've got cartilage is too far back. You can do lots of different things. But as a general rule, you put the posterior septal angle into the anterior nasal spine, and then there is a little bit that sits forward to that. I hope that's clear.
Yeah, exactly, sir. So
yeah, so clear. Thank you.
So we just complete our septum modifications, because sometimes if your patient maybe have some dorsal part of the deviation of the septum, then we reconstruct this dorsal part of the L strut also. But I usually reconstruct it later. First, I move my bony pyramid modification if my patient, because that is the little bit crude work, and then after the first I complete my bony pyramid modification, then I come down my mid-vault modification, mid-vault work, and then I come down to the tip work. So then we move for this bony pyramid modifications. So give me the seizure, I just separate. So bony pyramid modifications, usually we have the different type of the other methods, like osteotomy, यहाँ से पकड़ो, like osteoplasty, but most commonly we usually use that is the osteotomy. And really in the rhinoplasty there is a two basically procedure that is little bit confusing and too difficult. One is the osteotomy and that another is the ala base excision. We a little bit biased about that the patient need or not. So we have to need the comprehensive knowledge of the regarding indications, anatomy, all of these things. So we separate the skin. This is the cadaver, not in the live patient. So we just one side we expose more. यहाँ से पकड़ो. So first we know exactly that what is the osteotomies. So by the definition, osteotomy is really the control factor of this nasal bone just for the desirable width of this bony vault, okay, and for the getting the desirable dorsal aesthetic line. And really in this osteotomy also we have the challenging factor. Why? Because while we are performing this osteotomy that we cannot see, we just feel it. And another problem on that the thickness of nasal bone. The thickness of nasal bone on this same patient from the top, from the mid, from the down, that is the different. So there is lot of variation in the length. So that's why this osteotomy is one of the most difficult and least controllable step in the rhinoplasty. Okay. So for actually you need the complete morphology of the bony nasal vault. Either your patient need or not osteotomy, you know about the different type and indication of the osteotomy, and you know about the sequence and the pattern of the osteotomy, and you have definitely you know about the different type of the knowledge of the osteotome, which type of the osteotome for which osteotomy you need. And also you have the knowledge regarding the surface landmark also, what is the surface marking. So first we learn regarding the morphology of this bony nasal vault. So in morphology, first you look that, you give me the sharp scissor on periostem elevator. First you learn the different component of this bony nasal vault. This entire bony nasal vault that is consist by a pair of nasal bone and ascending process of the maxilla. Basically these have the 6 important attachment: superolaterally the lacrimal, and then anterolateral, that is the ascending process of the maxilla. Superiorly we have the nasal process of frontal process of the nasal bone, and inferiorly we have this upper lateral cartilage. And on underside, top to bottom, we have the bony septum. So regarding the size and shape of this entire nasal bone, if you compare the size of this, then the size of this nasal bone in nasofrontal suture area, this is nasofrontal suture area, this is the widest, around the 14 mm. But if you come down, then it's gradually narrow and then again it widens. So the size, variation in the size of this nasal bone is responsible for this hourglass shape of this bony vault. That's why we get on the dorsum the dorsal aesthetic line. Okay. So why we get the dorsal aesthetic line? Because there is variation in the size. This is around the 14 mm, you come to 10 to 12 and around the 10 and then 10 to 12 in this area. So that is responsible for dorsal aesthetic line. So what exact significance of the dorsal aesthetic line? Because the dorsal aesthetic line, they depict the contour irregularities. If you have a excessive curving, that indicate either the over wide bony vault or the pinching of the mid vault. Okay. And then the length and the thickness of the nasal bone is the different. Ideally, the length of this nasal bone, that is around the 2.5 centimeter. But the thickness of the nasal bone, that is also vary from the lower part also. The lateral nasal bone, the thickness is also in the mid part of this lateral nasal bone, that has the highest the thickness. Sometimes, you know, some patient basically have very short nasal bone, very short nasal bone. Then if you do the osteotomy in that case, you have a lot of chance of the fragmentation of this nasal bone. So, and in that case, what happened? This upper lateral cartilage have lost the support, and this inferior-medially collapse. So ultimately, the patient develop the inverted V deformity. What is the inverted V deformity? Then this upper lateral is the inferior-medially collapse when a patient have a very short nasal bone. This is the inverted V deformity. Okay, and sometimes when you have a bump, lot of bump, more than 5 mm, and when you excise the bump, then there is a space created between the nasal bone and the septum, that is the open roof deformity. Okay, and another thing, that is the width of this nasal bone is also, because the width, there is a two types of the width of this nasal bone. One is the bony base width. What is the bony base width? That is the distance between both sides of the ascending process of the maxilla. One is the dorsal width, the width between this nasal bone. Okay, marker dena. So sometimes if your pathway of the osteotomy is higher and your patient have a excessive bony base width, then what happened? That part is just feel like a stab. That is a stair-step deformity. Okay. So look that this is the junction of the this is the ascending process of the maxilla, and this is my nasal bone. Okay, and this is the pyriform aperture. This is the pyriform aperture.
Sunil, can you just show from the side view?
Yeah, अरे उसको बुलाना कैमरे वाले को. Definitely show boss. उसको बुलाओ कैमरे वाले को, उसको बोलो यहाँ से दिखाना ये lateral side view. यहाँ से दिखाना, वो कहाँ है, थोड़ा सा इधर करो. So basically after the morphology, in the morphology we just learn the different width, length, thickness, size, shape of this nasal bone, and then you also know about the different type, the knowledge of the osteotome also. There is a two types of the osteotome then usually use. One is the straight osteotome, another is the curved osteotome, or one is the guarding and one is the without guarding osteotomes. Okay, so when you use a straight osteotome, then definitely you have the less injury of your periosteum, you have the less edema. But when you use the guarding osteotome, then you use osteotome dena per letter. When you use the guarding osteotome, then this part throughout the osteotomy you can feel this part. That part is easy to where you are working. But on the other hand, this part damages the periosteal attachment. So the literature says that when you have the more edema later. But whatever you use, either the straight or either the this guarded, the patient deformity that should be correct, and it's a hardly matter, I think, in my opinion. Dr. Sandeep, what you suggest then regarding the guarding and the straight osteotome, regarding the post-op later edema or bruising?
I don't see much difference. The only thing is it depends on the osteotome itself. I mean, some of those guards are very, very wide. So if you look at when you buy an osteotome, lateral osteotome, if you're going to use that, then make sure that the guard is very, very thin, and that way you're not going to get more edema or more trauma. And it's also much easier to use when the guard is relatively thin. But some of the osteotomes have got very, very wide guards, and they're more difficult to work with, and you probably do get a little bit more soft tissue trauma with it. But in the long run, does it make a huge amount of difference? Probably not. I don't think so. But when I choose osteotomes, there's one specific osteotome I like from a company which has a very, very thin guard to it. So you can still feel the guard, but it's causing very little trauma.
Yes. So there is now the different type of the osteotomy also. So when you deal with the medial most part of the nasal bone, that is the medial osteotomy. When you deal with the lateral most part, that is the lateral osteotomy. And when we deal with the mid part from the top to bottom, that is the intermediate osteotomy. Okay, and one is when you deal with this part, that is the transverse or root osteotomy. So these are the different osteotomy we use. Indication, if you discuss regarding the indication of these osteotomy, regarding the medial or lateral, indication is the same. When you want to a straight deviated dorsum, when you want to a narrowing of a over wide bony vault, or sometimes when you have a just when you have a widening of a pinching bony vault, okay, and for getting the desirable dorsal aesthetic. These are the different indication. But for the intermediate osteotomy, the indication are the different. Okay, for the intermediate osteotomy, when you use the intermediate osteotomy, then the indication is when you have a asymmetrical nasal bone. One side nasal bone that is the longer than other. Okay, and one side nasal bone is the concave and one side is the concave. So either you use the, maybe discuss regarding the sequence. So either you use the medial and lateral, it hardly matter in a normal case. But if you have a crooked nose, in a crooked nose, because one side is the deviated convex side and one side is the concave side, in that case the sequence is matter. Because if you use the medial, intermediate and lateral osteotomy, then first you use the intermediate osteotomy. Why? Yes, for stability. Because if you destabilize this part, then how can you do the osteotomy in destabilized part? So first you develop the intermediate, do the intermediate osteotomy. And another important thing, when you do the intermediate osteotomy, then which side first you do, either the concave side or convex side? Concave side. Why? Because if you, this is the common mistake do by the beginners. When you do the convex side, they start the convex side. Because first, if you do the osteotomy on the convex side, then this bone does not allow to come in the midline. So first, you free this part from the attachment, then this bone allow to this deviated side in the midline. So always. And if you go the literature also, the concave side, convex side nasal bone, lateral nasal wall is thicker than the concave side. So the sequence, whenever you use the intermediate osteotomy, you always remember the sequence. Now we first start the medial osteotomy. Sir,
just before you do the osteotomies, can I ask a favor? If you remember back to AOICon earlier this year in January, there was a quiz and there were some students on there who won the quiz, and I said to them we would be teaching them. I was meant to be teaching them today, but actually because you're doing this, I asked them to join your meeting and to join this today. So there should be some, hopefully the students are on here today and I'll teach them next week online. But if you just, before you do disrupt all of this, if you could just very quickly just summarize the anatomy as you see it, because obviously with the skin, it's a very unique way of showing the anatomy. So if you just go through the lower lateral, upper lateral, and bone very, very quickly, it'll take you 2 minutes, and it'll be very useful, I think, for these students who hopefully have joined. And to the students who have joined, I apologize, I won't teach you because Sunil's doing such a good job today. I will teach you next week. I'll wake up early next week and teach you in India from next week. And anyone who wants to join that is also very welcome. I'll share that link with Sunil. Whoever wants to learn some very basics parts of rhinoplasty, I'll teach next week as well. But while you're there, you've got a beautiful view. So maybe if you can just, from a student's point of view, just show them the anatomy, that would be great.
Yes, sir. So I think we already discussed about this alar cartilage. This is the upper lateral cartilage. This is your bony vault. This is nasal bone. This is the ascending process of the maxilla. You all clear these things. Now the medial osteotomy, some book mentioned the name is the paramedian, some is the median, so you never bias about that, because in each osteotomy the important thing where you engage your osteotome and the pattern, what is that? The pattern of the osteotomy, that is the important. So in median osteotomy, paramedian osteotomy, why we call the paramedian osteotomy? Because we placed it, we engage it in the parasagittal manner. just few lateral to the central area. So look that how I just engage it, and then we just feel this part is a little bit higher rather than so we feel by your index finger, and then you use that two tap technique. Marna. So we engage it initially, we engage it like this, and your pathway, that is the fed 15 to 20 degree away. Okay, like this. Yes, 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 yes. So look that throughout you can feel by your index finger where you are working. So just little bit higher the angle of this part of your osteotome you can. Yes, yes, it's okay. So what is the upper limit? That is the intercanthal line. Okay, so this is the one method of the paramedian osteotomy. There is another method. Sometimes in this method what happened when you have a severe crooked nose, when this septum is also osteomized, then you have sometimes the keystone, you disturb the keystone area when you do both sides. So there is another method of Dr. Pond, that is a very good method. Then there is the transvestibular paramedian osteotomy. So in transvestibular paramedian osteotomy, you pass this your osteotome along this mucopericardium. Look that I like this, and you go and you bypass your this K area, and then you use like tap tap, 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 tap tap. So you bypass this. This is the keystone area. So you bypass this keystone area, and you just go gradually forward. Okay, tap tap, tap tap, tap tap. So this is the transvestibular paramedian osteotomy. So you can preserve your keystone area. So this is about the medial osteotomy. Either it's depend, either use. I usually use the transvestibular paramedian osteotomy. Okay. Now, after the median osteotomy, if you use the median and the lateral, then I usually use first the medial osteotomy, then the lateral osteotomy, because intermediate osteotomy no need in each and every case. Okay. So this is the sequence, and then the lateral osteotomy. Regarding the lateral osteotomy, the two things are important. One is the approach, another is again the pattern. So approach, either you use the external or the internal. External, that is the basically the osteotomy used, that is the external perforating manner. Another is the internal, that is the continuous manner. So for both, the pattern is important, either because this is a very again confusing high, low, high. So first you clear in your mind. One side I do the मेरे को देना वो lateral osteotome.
Neil, sorry to disturb you. I have another engagement, so I'll have to take leave. I hope you don't mind.
Okay, thank you, boss. Thank you for joining.
Yeah, maybe next year, if you give me a bit more notice, I can be here for longer.
Yeah, thank you, boss. Thank you for joining us. Okay, boss.
Nice to see you, Sandeep.
Yeah,
nice to see you, Sandeep. Take care. Bye-bye.
So now, again, for each and every osteotome, where you engage your osteotome. Okay, so first we demonstrate the internal continuous manner. For the internal continuous manner, where you engage your osteotome, you identify this is your inferior beneath. Okay, so just anterior to lateral end of the inferior beneath, you make a horizontal incision 3 mm around. Okay, okay. Now then you make the incision, and then this is your osteotome. This is the guarding end, and this is the cutting end. Okay, so just you use this nasal speculum and you engage it. The guarding end, that is the outside. Cutting end, that is the inside. You clear this one? Okay, like you just go, and once you engage, then that should be like around 70 degree around the vertically like this, not like this initially. and look that how I hold this one. Okay, now this one, like you scrape little bit. Okay, so you firmly engage it. Okay, and then just like you use the 2-tap technique. Ask your assistant, tap 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 like this, not continuously. Okay, and like just you tap 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 tap, dhire dhire. Okay, and then you go gradually down. Okay, go gradually down. Tap 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 tap. So okay, now the pattern. How you learn the pattern? That there is a 2 word. One is the high, one is the low. High, that means towards the dorsum. Okay, low towards the maxilla, ascending process of the maxilla. You know, initially when the osteotomy is discovered by the Joseph, then the pathway just to fracture this nasal ascending process, that is the lowermost part of the piriform aperture to the uppermost part, that is the same, that is the low, low, low. So once we use some, then the people realize, Webster realized that if we change little bit higher, then because the problem is what happened when we fracture the lowermost part of the piriform aperture, then because of the same area, the lateralmost part of the upper lateral cartilage is attached. So the lateral end of the upper lateral cartilage is medialized. The patient developed the airway breathing problem. And at the same side, the head of the anterior inferior turbinate is also attached. So he suggests rather than you go low, just go little bit higher and you preserve that Webster triangle area. So we go just little bit higher, just upper end of the anterior turbinate. Okay, and then again low, and then once you, because if you go low, 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 then you, once you reach at the intercanthal line, then you enter in thick part of the nasal bone, and that part is sometimes damaged, and that have a forward and backward movement, that is the rocker deformity. So he suggests rather than go low to low, the high, low, and again once rather than you enter in thick part, you go high up. So the standard pattern is the high, low, high. Okay. But again in the rhinoplasty there is a different type of the deformity. Suppose sometimes you need the excessive movement of your bony pyramid, then you just go the low to the low. Otherwise the high, low, high, that is the standard pattern of the up. Now look that where we are actually working. Tap 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 tap, because I feel my guarding end of the osteotome. Okay, and if I open it, then just tap tap, look that, tap 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 tap, you can appreciate. So what I am doing, I am fracture my ascending process of maxilla, not nasal bone. So this clear in your mind concept, when in lateral osteotomy we fracture the ascending process of the maxilla, not nasal bone. And if you look on the outside, where I am usually marker dena, I am in the nasofacial groove. I am almost in the nasofacial groove. This is nasofacial groove. Okay, and where I engage this one, I engage in this part. This is the Webster triangle area. I engage because हमने इसको यूँ लिया. So I engage my little bit higher. So I preserve my Webster triangle. Now then, once you come just parallel to the this face, then you change your grip. Earlier I hold like this, now you hold like this. Okay, then tap tap, dhire 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 dhire, tap 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 tap. And one of the important things, sometimes if you gradually go tap 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 tap, and then you just change it little bit, because sometimes if you have a strong nasal bone, a strong ascending process in a young male patient, then this osteotomy is displaced. Osteotomy is displaced because if you compare the thickness of lateral nasal wall in the lower part, that is around the 2.5 mm, that is the maximum in the mid part, rather than compare in the upper and lower part, that is around the 2.35 and something. So just you move like just, and you assure that you are not in the your osteotomy is not displaced. Just tap 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 tap. Yes, tap 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 tap. Stop. So now where I am almost at the intercanthal line. The line that connects this medial canthus, that is the intercanthal line. So once you reach at the level of the intercanthus line, just you go high up. Okay. So my pattern is the high, low, high. Okay. Just tap 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 tap. So look that I almost met with my this paramedian osteotomy. Okay. Now what you do on the right side, you rotate it on the clockwise like this. Like this. Okay. So now this part on of lateral nasal wall is free. Okay. So this is the internal continuous manner, and we complete free the attachment of lateral nasal wall from the medially by the paramedian osteotomy and laterally by the lateral osteotomy. So this is the internal continuous lateral osteotomy. Okay. On the other hand, if you want to do the lateral osteotomy by the external methods, so in external methods what you do, first you mark your nasofacial groove. You mark your nasofacial groove like this, the cheek and this junction between the nose. Okay. And then you make a stab incision. You make a stab incision like this. Okay. Now where your stab incision, just like if you on this side, where your stab incision, this is the my nasofacial groove, so my stab incision is just on the pathway where this is our pathway. Okay. That is the same. So I just make a stab incision, and then I just, for this osteotomy we usually use this 2 mm Medicone instrument. Okay. So just you क्या हो गया, you pass it and then allow. So in this method, just we have a multiple perforation in lateral nasal wall, just like a postage stamp manner, just like the postage stamp manner. And ideally, the distance between the two perforation, that is around the 2 mm, just for make easy the green stick fracture. And how you hold your osteotome, that is around the 70 degree. Okay. Just make tap 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 धीरे धीरे tap tap by the same nick you engage it, and just 3 or 4 multiple perforations. Tap tap. And the angle is around the 70 degree, because if you have the straight, then you have the chance of the damage of your bony septum. So rather than you go just oblique manner. Yeah, angular artery is lower downs. If you are the more low, then you have the chance of angular. Otherwise, there is no. Tap 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 tap. So after your multiple perforation, then you fracture it just like this one. So this is the basically the external manner. Sandeep sir, you want to add something regarding the external or internal osteotome?
No. I think you've explained it very well.
Yeah, Kavarji? Yeah.
Yeah, I think you've explained it extremely well. No problems.
Yeah, because when we engage that, when we perforate, then just go higher up or perforation of the Webster triangle. Okay, so now either it's a big matter of debate, either is the internal or is the external is good. Okay, literature says when you use the external perforating, that is you preserve that your periosteal attachment, and that is a more precise, so you have the less edema later. But the disadvantage on the other hand, that you have the scar. And for the internal, the advantage, you have a consistent narrowing, but the disadvantage, you damage your periosteal attachment. But like Dr. Pond said, that in the practical life, it's hardly matter. Once you do the more and more cases, then in some cases you need the external or internal both. Okay, ultimate the thing, how you are more confidential, ultimate your patient deformity, that should be correct, that is the more important. How your professor, how your boss is doing, how is your learning, that is the more important. So you never reach it like you just go in some workshop and then someone asks, then last 20 years the external is good, I am doing the external, so you never reach it. What you are more feeling. So this is regarding the lateral osteotomy. Okay, we already discussed regarding the intermediate osteotomy. In intermediate osteotomy, just we mark between on this line. Okay, we mark from this line from the outside, like this is the nasofacial groove, this is the top part of the dorsum. So we mark like this and just make a stab incision and just like the multiple perforations. So we just need for a more moment, but definitely whenever we have the certain indication, then we use osteotomy. Okay. Now sometimes after the intermediate osteotomy, the median osteotomy, the lateral osteotomy, in a crooked nose case, when you remove the splint, still the nose is deviated and it's too frustrating. So what is that reason that? So in some cases, the root of the nose is also deviated. And if the root of the nose is not correct, then still the patient have the deviation. So when your patient have a root of the nose is deviated, then you need the transfer. This is root osteotomy. So in root osteotomy, you identify the intercanthal line. Okay, you identify the intercanthal line and just you make a stab incision here and just like the external perforating manner, multiple perforation, and you just free the attachment from the root. Okay, so your root of the nose is the deviated part, that is the correct. So this is a different type of the osteotomy that usually we use for the correction of the. And now there is other methods for modification of the bony pyramid, like the Piaggio. But you have to know the basic knowledge. Okay, you have to know regarding the osteotomy by this osteotome. Then later, once you do the more and more cases, then you can also develop your habit with the Piaggio or other methods, by powered instrument also other methods. But this is you have to know about the basic. So regarding the osteotomy, have you any query and any questions? Yeah. When with this root of the nose is deviated, just for straightening the root of the nose, that is the simple, just to make a hole. And there is so many beginner might ask, then they have they are afraid, then if you do the osteotomy, the entire nose is fall down, sunken. So no, it's not happened, because the thickness of this upper part of the nasal bone, that is around the 14 mm. That is the two. This part is so thick, so this part act as a cantilever for this entire nose. So, but you do it in judicious manner, so there is no such type of the complications. Also, this is the indication when your root of the nose is deviated, then you do the transverse osteotomy. So when you in the medial and lateral, that either can use the medial or lateral first, never bias. But if you use the intermediate, then the sequence, that is the important. Okay. Intermediate and then medial and lateral osteotomy. Okay. So sir, the osteotomy part is finished. So you want to add something for beginner friends, sir? वो देना ही मार्क कर देना tooth for sub. This one. Almost this is the junction between the nasal bone and the ascending process of the maxilla. We break this part. Yeah, through the junctions. Okay, through the junctions. So this is the intermediate osteotomy. This is the paramedian osteotomy. This is the lateral osteotomy. So look that we complete free this nasal bone. We have attachment on this part. Okay. This is the intercanthal line. So we break this part. Okay. So just for desirable the movement of this root of the nose. Yes, yes. We medialize like this one, like medialize. So basically, or why we free this one? Because we want to straightening. So once we free this from the rest of the maxilla, from the medially, superiorly, and then we refix it, because the goal of the osteotomy, we want to reposition of this nasal bone but we maintain the stability. This is the most important. We maintain the stability. So we just fix in a new position. We fix in a new position. But how can you fix? When you separate it the surrounding rest of the attachment, then we shift it in the midline. So this is the goal of your osteotomy ultimate. Yeah, that's why I'm saying now. Look that initially, if I engage lateral osteotome like this, this we engage it higher, because look, this is the lowermost part of the piriform aperture. What is the piriform aperture? The boning opening of this nose. That is the piriform aperture. So if this is the lowermost part of the piriform aperture, so if we engage your osteotome this in lowermost part of piriform aperture, and then we go just like go. So this is the low. But if we escape this part and go little higher, this is the high, and then again like this, and once we reach at the level, then we rotate it like this high. Clear?
Banana line. It's called banana line.
Yeah, banana line. Perfect. Your banana line. So this is the high, low, high. This is the standard. Because when we do the high, then we preserve this attachment. But if you rather than you engage this osteotome just like low, that is low. But we make an incision here, uppermost part, just upper end of inferior beneath. Clear? So this is the high. Otherwise it's so confusing. What is the high? What is the low regarding the osteotome? Yeah. Yeah, it comes because these lateral and paramedian, because just this is the lateral and paramedian is just like this, so already joined. So we just free this remaining part of the nasal bone from the rest of the attachment in the transverse osteotomy. Okay? Yeah, combined. We combine. If we need, otherwise if your root of the nose is already straight, then there is no need to the transverse osteotomy, or motto is solved only by joining the paramedian and the lateral osteotomy. We free this lateral nasal bone. That's why the median osteotomy, that in the fade away in the 15 to 20 degree lateral, just for meet both these osteotomy. And suppose if your pathway is rather than like this, if your paramedian is straight, then in case you need this transverse osteotomy, because we want to meet getting for the more moment. Okay? मेरे को स्प्रेडर ग्राफ्ट देना. Yes. Yeah, posteriorly. Posteriorly, basically, first we create this L strut. Okay, first we create the L strut, and then after creating the L strut, if this on the posterior side, if you need a perpendicular plate cartilage for the graft purpose, then you harvest it, or if your bony part of the septum is deviated and that causes the functional problem, then you remove it. Otherwise, if your bony part is the midline, then is no need. If your patient have only the cosmetic problem, you need only the septal cartilage, there is no need. Okay. So after the bony bolt modification, next important step of our G step, that is the MIDVAULT modifications. Either in the MIDVAULT, your patient maybe have the augmentations or like the straightening. So for the modification of this MIDVAULT, we usually use SPREDER graft or other form of the SPREDER, that is the SPREDER flap. Okay. So whatever type of the graft in rhinoplasty we use, there is 3 or 4 things are the important. First, the indication or purpose of that graft, why you use. The second, ideal dimension of that graft. The third, how you fix it, how you place it. The 3 things are important. Whenever you use, then if you ask why you use this graft, this is the indication of this graft. Then when your ideal dimension, and then how you fix. Suppose you want to use the SPREDER graft. There is a certain indication of the SPREDER graft. When you have a deviated dorsal septum for correction of that, and sometimes for correction of the open roof deformity, and sometimes when you have do correction of the inverted V deformity, sometimes when you have a existing internal nasal wall insufficiency. Okay. And sometimes when you want to good refined dorsal aesthetic line. These are the different indication of SPREDER graft. Okay. Indication is clear. Now ideal dimension of the SPREDER graft. The length of the SPREDER graft, that is usually 25 to 30 millimeter long, and the thickness is around the 2 mm. Okay. Now how you place it is the important thing. So how you place it, like this is the SPREDER graft, then you just place it like you just create a pocket. We already have the pocket, this mucopericondial pocket. Okay. So between this mucopericondial pocket, we place it like this. We place it like this on this side and on the both sides. So the one end of this SPREDER graft is on under surface of the distal part of your nasal bone, and then this lower part till at the level of the anterior septal angle. This is the basic. Sometimes if you need the more strong support of this anterior part of the septum or septal extension graft, whatever you, then the length of this lower part is increased till the level of the ear. This is the extended SPREDER graft. Okay. So you just pass this one like this. This is the nasal bone, so under surface of this, and then you pass a needle from. Yeah. Yeah. How you take it? Because. Yeah, we just cut it from this septal cartilage like this. Give me the block then. Because whenever you make the carving of your cartilage, then first you develop the sense in your mind, then what type of graft, because once you cut it and then you think, I think the septal extension graft, I think the LF, so first you create what graft, so because you have only this one. So first you make you just identify the long axis of this piece. So this is the long axis of this piece. So along the long axis of this piece, just we make the incision like this, and then this is the part of that. And if you want like as a extended SPREDER graft, then basically according to the more length you can use it. So this is the way then you can make. And the upper end, that usually this part, that we cut it obliquely like this. This is the obliquely. So it's snugly fit under surface of the nasal bone. In the rhinoplasty, there is a short things that make the results different. So this is the way. Then now, because the fixation of this spreader is little bit tricky for my beginner friend. So thickness is around the 1 mm. Ideally, the septal cartilage is a good part. Okay. Then you just hold it by this cartilage holding forceps like this, and you pass this needle from the one side to the another like this. Yeah, but the both side that should be same. Okay. Then now give me the orthopedias. In rhinoplasty, whenever you use the any fixation, usually use the 4 OPDS. Okay. So how you use the 4 OPDS? Then you pass this 4 OPDS from the one side to the another side, just like you pass from the one side to the another side. उसको पकड़ना मुकेश, उसको पकड़ना. This cartilage is a little bit brittle because this is the old cartilage. 1 month back when I do the septoplasty, then I preserve for the demonstration. So this is a little bit brittle. So like this, and then again from on this side to this side. First on the midline, then on the anteriorly, then on superiorly. So this is a type of a horizontal mattress suture. Okay. Then just whenever you use the net, use a double knot. Double knot. You always use the 3 double knot. Cut it. So first you fix from the midline, and then one on the anteriorly and another on the superiorly. So first you fix the 3 structure. First you fix your 3 structure. It's a type of horizontal mattress suture, 4 OPDS suture that usually we use. Because if you fix the all 5 structure, then it's little bit difficult, but once you do the more and more cases, then definitely you can fix the all 5 structure simultaneous. So this is the easy way to fixation of the spreader graft. And the role of your assistant is also important. Definitely, Mukesh is a very good assistant. He knows what the next step. So then you remove this needle, and then just we fix the. इसको कोई ज़रूरत नहीं अपने को ultimate remark करना. Then all 5 structure you pass from the. इसको पकड़ना. This is my right side of the spreader. Right side of the upper lateral, then this one, and then you pass this one. So hump resection, because now the things are destabilized. But if a patient have a cartilaginous hump, then we already excise this part by okay. Suppose you want to remove this bony part of the hump, then we have a different methods. One is, give me the rest dena. This is the simple traditional methods. We have this Medicone rasp. So then you hold this, and you hold firmly the head of the patient, and you have this elbow movement like this, like Dr. Pond told that you just like this, okay. And then after the rasping, you just give a irrigation of the water you have the less chance of the callus formation because the bone particles you remove. Or either you can use your ear, like we have all ENT surgeon have the drill. So you have a long burr, then definitely I show you tomorrow next the cases. So you can use that. And just you lift up your flap and then you can use the powered burr also. Another recently we have the Piaggio also. But in the Piaggio the things are that's little bit take time just for rasping. So this is the simple method, but in this, because the things are destabilized, so if we rasp it, the entire nose is disturbed. Suture. Pradeep Goyal sir. Sir, any your comment?
No, you have an excellent demonstration of almost everything you had covered.
Thank you, sir. I learned all the things from you, sir.
Something you want to say about septal extension graft?
Yes, definitely. When we move after the next, because the last step we have the tip modification of the MIDVAULT modification.
Okay.
Then we'll discuss.
You will cover in that.
Yeah.
Okay, that's great. That's great.
So now from this side to again this side. Then again in the spreader septum. So this is the this way we fix this spreader graft. It's again horizontal mattress suture. Okay, so the reconstruction is important in the so many workshop and conference. So so my beginner friend they ask, then sir, in each and every case, is there a need of the upper lateral and the septum? Is there need of the septum? So they ask, is there need in each and every case? That it's my personal opinion. You can separate the upper lateral and the septum in each and every case, because once you separate the upper lateral and septum, then it's easy for you for the degloving of your mucopericardium is easy. And if you have, most probably if you have a crooked nose, 100% without separation of the upper lateral cartilage, you cannot correct your septum. But again, the important thing, suppose your patient is not crooked nose, and ideally there is no need to separate the upper lateral and the septum, but you separate upper lateral and the septum, then you reconstruct it properly. Because this is the rule, when you correct the abnormal anatomy, you never disturb the normal anatomy. But for learning, if we disturb the normal anatomy, then we have to reconstruct it again. Okay, so within like in crooked nose, it's very difficult to correct without separation of the upper lateral. Then the same, you can use 1 or 2 suture, at least 3 suture you need. Okay, and sometimes if you damage this K area, then you pass a needle from this side to this side, and then you come back again, you fix it. Okay, and this is the spreader graft. Why we use the spreader graft? We already discussed the indication of that. So it spread this upper lateral cartilage just to maintain the internal nasal wall. Like how 15 number the na? This is your upper lateral. Okay, this is your upper lateral, and there is a angle between this septum and this upper lateral that is around the 15 degree. So we just use this part of cartilage and we spread this cartilage upper part. So that's why we called spreader graft. Okay, 15 number, 11 number blade. So this is about the spreader graft. And now sometimes what happened, suppose you have a lot of cartilaginous hump. Okay, then you excise this cartilaginous hump. Obviously when you have a axis part of this cartilage part, then you also have the axis part of the upper lateral also. Okay, so in that case what you do, you want to narrowing of this mid-vault, then you separate this perichondrium from this upper lateral, and then some part you rotate like this. Then you suture it. This is the spreader flap. The motto is the same. Sometimes you don't have enough cartilage for the spreader graft. Then you can use the spreader flap. Okay. So these usually two basically technique, spreader flap or spreader graft, usually we use for the maintain the integrity of this internal nasal wall. Okay. So now we come down for or the sixth step of golden step of the rhinoplasty, that is the tip modifications. Okay. For understanding the tip modification, really पानी डालना इसमें थोड़ा सा सूख रहा है specimen सूख रहा है. So for the tip modification, first you know the all important surgical landmark regarding the tip. Okay. So if we discuss the important surgical landmark regarding the tip is like this. So we have some important 4 subunit regarding the tip. This is the, for a normal surgeon, for a ENT surgeon, this is the entire rigid tip. But for the rhinoplasty surgeon, this central part, that is the tip lobule, that is on either side defined by the tip defining points. Okay. And then laterally this part is the ala. Ala have the two, this part where this connect with the cheek, this is the ala base. And this free margin is the ala margin. Okay. And another, this vertically structure, this is the columella. Okay. That divide this nostril in the two part. And another, this is the nostril. So this nostril cavity have the two important part. One in the apex of this nostril, this is a notch. What is this one? The soft triangle. And why we have the soft triangle? Because if you learn the anatomy of this dome area, then the cephalic part of this dome, that have a notch. So in this part we have the deficient cartilage part. So there is very dense approximation between the skin to skin. So if you have the minor injury in this part, then you develop the notching later. And on the floor, this posteriorly cylindrical area, that is the seal of the nose. So these are the important landmark of the tip. Okay. Now for understanding how you modify the tip, first you learn the tip characteristics. We have 3 or 4, 5 tip characteristics. One is the volume of the tip. What is the volume of the tip? That means the size of this lateral crest. Another, that is the width of the tip. What is the width of the tip? That the distance between the two tip defining points. What is the tip defining points? Tip defining points is the junction of this medial part of the lateral crest with this dome. Where tip defining will fall, the junction between the medial part of the lateral crest and the dome part of the intermediate crest. Okay, this is the tip defining. So ideally the distance between this tip defining point, that is the width of the tip. Okay. Another is the definition of the tip. Definition, that is the angulation of this dome. Look that. This is the angulation of this dome. That is the definition of the tip, that decide. Okay. Ideally the distance between the two tip defining point is the 6 to 8 in the female patient, 8 to 10 in a male patient. Now another is the projection of the tip. What is the projection? Projection is the distance by which this tip project from the face. So from this tip defining point to the alofacial junction, this nasofacial junction. Got it? So volume of the tip, yeah. So volume of the tip, width of the tip, definition of the tip, and projection of the tip, and last is the rotation of the tip. Rotation of the tip basically is the inclination of this tip from the rest of the face, like on this side or like down. So usually we measure in the nasolabial angle, that usually around the 90 to 95, that is the acute in a male patient, but little bit obtuse in a female patient, then 95 to the 110 in a female patient. So usually patient have abnormality regarding the these tip characteristic, okay, regarding the size, regarding the definition, regarding the width, regarding the projections, okay. So there are 5 techniques by which 95% primary tip deformity you can correct. 95% primary tip deformity. Rest of the 5% tip that you need the different. What 5 techniques? One, that is the columella strut. Another, that is the cephalic trimming. And then the dome creating sutures. Then the interdomal sutures. And then fifth, that is the tip refinement graft. So first we discuss these 5 techniques by which we can modify. First is the columella strut. Strut dena. So again, like whenever you use the any type of the graft, first is the indication. What is the indication for using the spread and this columella strut? Just for the projection, for make the good shape of the tip, and just to make the unified tip. So then after the indication, what is the ideal dimension? It is around the 20 millimeter long and 2.5 mm width and 1.5 is the thickness. That is the ideal dimension of the columella strut. And warmer part of our septal cartilage, that is the best part for this, using this columella strut. Now how you fix it? Then first you make a pocket by this scissor. First you make a pocket, pakadna Mukesh, just like this, okay. You just spread it and you make a space, okay. Now after making the ideal dimension, you create a pocket and then you insert it in this pocket like this, okay, and then you hold and they pass a needle. Needle pass karna. You pass a needle from one side to the another side. You pass a needle from the one side to the another side. Give me the needle. But again the important thing, if you pass this needle just like this and like this is the wrong method. Because if you fix it like this, then your tip is deviated. So the entry and exit of your needle, that should be on the same plane. Got it? And now how you fix? Then you give me the suture. You can use either the 4O or 5O PDS. If your street, then that is a cartilage of the rib cartilage, then you can use this 4O or otherwise 5O. So then either you can fix directly, or if you pass from this to this, the skin to skin, then the patient later feel the knot. So then you fix it subcutaneously. If your knot is subcutaneously, then later patient not feel. That is the good. So just like from this, ये needle हटाओ मुकेश. Again this cartilage is so weak. Then on this side, like this, पकड़ो उसको नीचे से. And again from another side to this side. So what we doing, we fix our columella strut. So this is again a type of a horizontal mattress suture. We use the 3-knot, but rather than you use, this is the wrong method to fixation of the knot. You always fix your knot along the long axis of your graft, like this. This is the right manner. So you fix it. You fix it like this. You always use the 3-knot. Cut it. So this is the columella strut. Now another you use at the base and on here. But your upper end of your strut, that should not beyond your dome area. Okay, cut it, scissor dena. So this is about the columella strut. Yeah, any questions? Not this note that comes under this flap. This
Dear
flap.
Sunil, could you please show the returning point? I forgot the name of the lateral cross of lower lateral cartilage. The point where reflecting from the descending limb to the intermediate crura.
What are you asking?
The point where meeting of the limb of lateral crura, descending limb, and the intermediate part, the point between them.
Yeah, basically this is a part, that is the tip defining part, that is the transition zone, this one. You ask this one, na? This is the attachment of this intermediate part, the dome part. So lateral end of the dome part and the medial most pass of the this lateral crust, that is the tip defining point, dome junction line. Mark dena, scissor dena. And the lateral most part of this lateral crust that attached with the accessory cartilage, small accessory cartilage. So this is the use of the columella strut. Okay. Now the next, that is the cephalic trimming. Okay. So it's a subcutaneous. Basically, it's the subcutaneous. When we cover it under the flap, that, and when we do this columella strut in a living patient, then the things are they have some strength. That the things are each and everything is opened. So otherwise that exact come under the flap. Okay. Now the cephalic trimming. So again the indication of the cephalic trimming when you want to reduce your volume of the tip. Okay. Then we excise, because this is the cephalic part of the lateral crust. This is the caudal part of the lateral crust. Okay. Now, how much you excise? It's again the question, how much we excise. But how much we excise, that is not important. How much we preserve it, that is the important. You know, because the old literature that mention the 6 to 8, because in rhinoplasty, mostly literature are the Western database. They have the thin skin patient. The 6 to 8 is enough. But in our scenario, we have the tough, thick skin. So around the not less than 10 mm. Marker देना. Not less than 10 mm. वो देना measure करने का. So you can measure it. Look that. You can measure it. Look that. If we measure it, that is around more than 10. More than 10. Okay. That is around the 13. So we just preserve 10 and rest, just like how can we just like we just mark it, and we can use like if we want to preserve the 10, then just like we mark it like this point. So the rest of this part we can remove. Yeah. For my male patient, basically at least not less than 10. In female patient, it's okay a little bit. So then how much we remove it? mark होते ना 15 number blade. So then we make a step, we cut और पकड़ना इसको यहाँ से, ये आगे से पकड़ो यहाँ से. So we make a step cut. And now just you pass a scissor. You can use for infiltration in the vestibular skin for my beginner friends, because for easy to the dissection. Okay, I usually use this needle, this scissor, sharp scissor, but for beginner friends, if you feel the problem, then we can exercise this in this way. So this we just exercise the cephalic part of this lateral crus. Now again, so many friends, they think when we exercise this, then we damage the scroll area. So you clear from your mind, then look that we not damage this scroll area. This is the scroll area. Okay. So you clear, yeah, because scroll area is around 15 mm overlapping between the distal part of the upper lateral cartilage and superior, and it's basically a ligament structure. So we need not damage the scroll area. And in the last, what you can do, then you make a suture again of this structure. So the reconstruction of the scroll area 50, then I. So we not damage, because sometimes when we see in the conference or workshop, we think we damage the scroll area. So we just make a suture it again, just like this is my scroll area. So we make a suture and we reconstruct it like this. Okay, but it depends how much you remove. Only the cartilage, only the cartilage. Though in cephalic trimming we reduce the volume of the lateral crus just to make the more malleable of this. Look that now again the same things are. So just to make more malleable this lateral crus. But the most important thing, just to prevent the alar retraction, at least you should preserve the 8 to 10 millimeter this lateral crus. Okay. So this is the second technique after the columella stud, then the cephalic trimming, then the tip sutures. So usually we need the sutures just for getting the more definition, that is the intradermal suture. So how you place the intradermal suture? Pani dalna. Oh, the intradermal suture, you pass this from medial to the lateral like this. From medial to the lateral, hold this one, isko pakdo, and then again go from the lateral to the medial. Then again go from the lateral to the medial, and then the note that should be on the medial side. Chhod do. So look that now the change the definition. So this is the dome creating suture. This is the dome creating suture. Cut it. Okay. So for getting the more definition of the nose, but the note that should be on the medially. Sir, Dr. Sandeep on? Sir है क्या? Join कर रखा है सर? Yeah, cranial tip suture, that is the different, just like a basically dome creating sutures. There is a new concept. In new concept, just they want this part of this cephalic part of this lateral crus, just like they want like this one. So the suture, that is this type of this dome creating suture, but the way like this, just little bit posterior to this one, and like this in the oblique manner, like this. They just yes, posteriorly, but the oblique just near the entry of and suture, just to evert this part. Look that, just to evert this part, just to evert in little bit cranial portion of your this dome area. So they are the cranial tip sutures. We discussed this in advanced step on the tip now. Cut it. So this is the cranial tip sutures and dome creating sutures. Okay, and then the sutures, they connect the both dome. That is the interdomal suture. That is the interdomal suture. So in interdomal suture, we reduce the width of the tip. Okay, again from this side to the another side. But they all the symmetry that should be maintained, है ना? Then again the double node. That is not too tight. If you make this too tight, then you create a pointed tip. If you have the too loose, then you have the widening or wide tip. Okay, so you never bias or confuse between the intradomal suture and the interdomal suture. Just like intercity express, they connect the two cities. So interdomal suture, they connect the two dome. This is the interdomal suture. Intradomal, that in the same, just to create the more definitions. Okay, cut it. It's not compulsory, in rhinoplasty there is no standard rhinoplasty. Not in each and every case you use the intradomal or interdomal suture. We just discuss a certain pattern. Sometimes if your patient have a good definitions, then is no need to the dome creating sutures. So just this clear in your mind that not in each and every patient you have to use this intradomal suture, and what the patient need. Okay, yeah, sometimes sometimes there is no need to the intradomal sutures. You just make the interdomal, but usually we follow this sequence. Then we need the intradomal and the interdomal sutures. See, knife है ना? So these are the like technique like the columella studs, cephalic trimming, dome creating suture, intradomal suture, and we use one more technique, that is the tip refinement graft. Just use of the tip refinement grafts basically just need more refinement of the tip. Okay, so there is a different like the cap graft, like the sealed graft, like the umbrella graft, but most commonly we use the sealed graft. We use the sealed graft. This small graft, just like in a sealed sap manner. Again, like the indication, like the ideal dimension, and either the fixation, whatever graft you use. Indication of the sealed graft, when you have a thick skin patient, when you have a refinement of this your infratip lobule part, when you have an axis part of the infratip lobule, and suppose you want to need little bit more projections in a revision case or a thick skin patient, then this you use this sealed sap graft. But needle dena, how you fix it? Because you fix it at the just anterior to this part. You pass in a needle and then you just fix it with this in this way. And this part, this little bit part, this beyond the dome area, This part is beyond the dome area, and ideally the distance, this is the shoulder part of the shield graft. That ideally at least 6 millimeter that should be. And we put a one suture here, one suture here, one suture here, one suture here. And this part gives support to the
superior side
dome or soft tissue annular. But sometimes what happened, this part, axis part beyond the dome part, that is the bend due to the thick skin pressure. So what you do, that the small piece of the cartilage you use just on posterior to this one. Okay, so this is the use of the spreader graft. Clear? Now, these are the 5 techniques that commonly we use basically for the primary tip cases. 95% cases you can do by this technique. Now, how can you do the rest of the 5%? For the rest of the 5%, for this central limb of the Anderson, you have some different techniques like the septal extension graft, like the septal replacement graft, like the tongue-in groove, like the modified tongue-in groove, like the modified tongue-in groove setbacks, for modification of this central limb of the Anderson. Okay, and you need the certain techniques for modification of lateral limb of this Anderson tripod. Procedure dena 15 number blade. So first we just open it, and for my beginner friends, I think you develop first the 95% cases is good for you. If you attempt the 95 cases, you left the 5% cases. So you build up your confidence. So now, first that usually use the septal extension graft. Okay. Now again, there is a confusion in the mind. Then why use the septal extension graft? You use the columella strut. Okay. So you clear from your mind the use of columella strut for a limited projection. But septal extension graft is a really a structural graft. When you need the significant projection, when you need the good foundation of the central limb, okay, then you use when you need the rotation also, either the upward or the downside. So this is the septal extension graft. Then again, after the indication, then again the dimension. This is the use of the repetition. Effect aane lag gaya. So the dimension, that is the 20 millimeter long, and the 25 millimeter is the height of this ideally. Okay. Then how we place it? Then just you fix it like this. Okay. And how you fix is really so important. Septal extension graft, it is really a so versatile graft. Sometimes you get some unwanted effect, and that create the patient lot of problem. How? If you fix this spreader graft like this, then the nose is over rotate. Okay, you got my point? And if you fix it like this, then you have a droopy tip, because these are the unwanted effect. So when you fix your spreader graft, then there is a different method. Either you end to end, either you fix from the this to this. This is the end to end, but this is the difficult. So end to side, that is the easy methods. Got my point? Now you just check, not beyond the margin of this medial crus. Okay, just like not beyond the margin of the lateral crus, and then just like वो लगा ना यहाँ पे, you pass a needle, first you check like you are okay. Okay, but not too much behind, because if you fix it just like this, then you have a groove again, you create the problem. Then you need again the one part of the strut more, and you don't have any cartilage now, so it creates the problem. So you just behind this limb of skin of the inverted V, and then just like, and then that should be straight, that should be exact or straight, not like this and not like this. Okay, then you put it, then you pass a needle. This is the end to side manner. Then you pass a needle. Give me the Mukesh, needle pass karna. Pass the needle. You pass the needle. Now give me the 4OPDS. 4OPDS. OPDS. So then again, दूसरा दोना यार ये क्या है? So just you pass from the one side horizontal mattress suture from this side to this side, and again on this side to this side. छोटा है suture, ठीक है. So we fix it. Hold करना. When you have the small suture, then you have the problem. ये दिखाओ मेरे को. So we fix it. Yes, good. Again along the long axis of your graft. Okay, just like this. Use the double knot always. Whenever you fix your any graft, then you use the 3 knot. Cut it. Suppose if you want like the good more support, then your spreader graft, the length of the spreader graft till at the level of like this, that is the extended spreader graft. When you are doing a surgery of a bender syndromes and you under projected tip, thick skin patient, and you need a strong foundations, then you can use this extended spreader graft. You can use. Okay, so then one more suture. So first on the mid and then at the bottom, because the fixation is important. इसको पीछे बांध देना, टाई कर देना. So from this side to this side. First we suture with the septum. Double knot, cut it. Now this part also that should sutures, because otherwise and this should be free. Okay, so just you pass from this to this. Dr. Hakim is there? हाँ वो लेंगे, अभी लेंगे.
I'm back, Sunil.
Yeah, boss. So we just discuss about the tip part. We already discussed about the columella strut, cephalic trimming, dome creating sutures, cranial tip sutures, and interdomal sutures for primary cases. But we just discussed some advanced deformities. So for how we modify the central limb of this tripod. So I just demonstrate about this septal extension graft. So I just fix this septal extension graft in the end to side manner. So really I just explained to my participant that the septal extension graft is a very versatile graft. If you are not fixed in the right manner, then sometimes you develop the unwanted effect like the over rotation or under rotation or something. So this is the use of the septal extension graft when you need the strong foundations, when you need the strong projections, significant projections, okay, then how you fix. Now another technique for the modification, some in advanced tip, that is the tongue in groove. What is tongue in groove? There is two words, tongue. Tongue, that means this medial crus. Groove, that means the space between the medial crus. Suppose this part is axis, you have a axis columella shoe. Suppose you have this axis part, you have the axis infratibular part. Then how you deal with, how you correct it? We want to reduce the columella shoe because there is good aesthetic pleasing nose. Ideally, we have the 2 to 4 mm columella shoe. The distance between the ala margin and ideally there is a gull in wing flight appearance. Okay, so when you have a more than this, then we want to reduce. How you reduce it? Then this both medial crus, we advancement on the rest of native septum. Okay, then when we advancement of this medial crus, then we rest of the present native septum. We pass a needle from this to this and we suture this medial crus on caudal part of the septum, that we call the tongue in groove. Okay, but sometimes what happened, then your distal part of the septum is weak, and then first we reconstruct, like in this case, you give me needle, then you advancement on that part of this medial crus, that is called the modified tongue in groove. You got my point? If we fix this medial crus on this septum, if you don't have this one, then on native septum of the patient, that is the modified tongue in groove. But suppose first we reconstruct this caudal part by the septal extension graft, and we just advancement of this medial crus, bada double prong retractor. We advancement like this, like in this patient, look that this is medial crus, this is medial crus. Suppose like we suture this, needle pass karna upar aur niche mein case. So this is the modified tongue in groove. So you got the difference between the tongue in groove and the modified tongue in groove. That means in tongue in groove you fix your medial crus on the native septum, but on modified tongue in groove you fix your medial crus on the septal extension graft. Now how you fix it? Again suture dena. Then ideally you can pass needle from this to this, but there is a very good methods. Kapil boss, this is your technique. Then how you fix your septal, basically you note that is the midline rather than on the skin or outside. So I learned this from your technique. Then you pass again from this to this, and then on this side.
Yes, I do, and I also learn from the other people, not my native technique.
But this is good because in the note that is inside.
Yes, yes.
But the important thing, the entry and exit of your needle, that should be same plane. So look that your note that is the inside. Okay? Your note that is the inside. Otherwise, sometimes if you go the skin to skin, then your patient feel that note. Cut it. So the same, you can use the one more sutures at the bottom and one on the mid. At least you need the 3 sutures. So you just clear the tongue in groove and then is modified tongue in groove. So the both technique used for significant for projections. But sometimes if your patient have a over projected nose and if you want the deproject the nose, because the mostly patient need the projection, but sometimes if a patient come and then ask you, I want my deproject my nose. So then in that situations, you just free this medial crust from this skin and then you section it. Suppose this is medial crust, you free, you section cut it and you overlap like this. Suture it and then that part, if you fix on this septum, that is the tongue in groove setback technique. Okay? That is the tongue in groove set. Yeah. You already clear about this tongue in groove modified? Suppose this is your medial crust. This is my medial crust. Okay? This medial crust is too long. Okay? So, we free from this skin, we make a incision and then we overlap. We shorten it, we deproject, and then we suture on the rest of septum, just like tongue in groove. That is the tongue in groove setback for deprojection of your nose. Tongue in groove setback. Okay. So these are the different technique for the modification of the central limb of the Anderson. Okay. And sometimes if your anterior part of the septum, like in the post-septoplasty cases or like in the binder cases, if your caudal part is too much deficient, then rather than septal extension graft, you use the septal replacement graft. So in that case, what you do, because in the post-septoplasty cases, you know, every surgeon left little bit dorsal part of the strip. Okay, so you use a fan-shaped graft, like give me the marker. In that case, you use a fan-shaped graft, just like a like in this is a fan-shaped graft, like this. So this part of the graft that you suture with the dorsal part of the residual part of the septum, and this part you use as a septal extension graft, and just you make another strip of cartilage with the suture, so you can correct it. Okay, that is septal basically replacement graft. So these are the some advanced technique for modification of the central limb of Anderson. Now you come on the lateral limb of this Anderson. Okay, so mostly in this lateral part of the Anderson, the patient basically have the problem regarding this lateral crust. This lateral crust have 2 or 3 or 4 common problem, common deformity. What? Regarding the size. Maybe it oversized. Okay. Second, maybe regarding the shape, because ideally shape of this lateral crust is the convex. Maybe he have like this. Okay. What is the name of that? That is the paradoxically lateral crura deformity. Okay. So either this lateral crust have the problem regarding the size, regarding the shape, or sometimes one another type of the problem, that is orientation problem. Ideally the orientation of this lateral crust distal end is towards the lateral canthus. Look that. But rather than sometimes towards the lateral canthus, if on the medial canthus, that is the cephalic malposition of the lateral crust. Okay. So regarding the size, regarding the shape, regarding the orientation, and sometimes regarding the strength. Sometimes it's so weak, so flimsy. So these 4 problem usually have this lateral crush. If the patient have a over wide lateral crush, you already know how you correct it. How you correct it? By the, when a patient have a big this one, then how we correct it? Cephalic trimming. Cephalic trimming. This is the first stage. This is the cephalic trimming. Now the second, that is the, if maybe a patient have regarding the SEP, that is maybe if the patient have और देना मेरे को, if the patient have like this, मेरे को देना, आपके पास वो पोस्टर है ना जो मैंने दिए थे, this one more, this one more, ये नहीं है आपके पास, वो नहीं है आपके पास. So maybe if the SEP is like this, then this is the paradoxically lateral crura deformity. How we correct it? Scissor देना. Paradoxically lateral crura deformity. So how we correct it? Then first we release, because it's very difficult in this, but we just try. Yes, we just spread it. We can use the infiltration also. So we just free. Because infiltration is good. When you use the infiltration, if you have a buttonhole in this vestibular skin, then you never leave it, you just repair that. Okay. Then again you fix, separate it laterally, because we put this suture for the scroll reconstruction, so I just leave it. So counter traction is, look that if that man hold this one, that is easy for me. So counter traction is always important. When you open the nose is also. So first you fix, separate it. Okay. Now if your patient have a deform, basically diffuse concavity, like entire this, like this, then you cut it and then you flip it like this. That is the lateral crura flip. You got my point? If your lateral crus have the diffuse concavity, then you separate it from here and 360 degree you flip it. That is the lateral crura flip for correction of the paradoxically lateral crura deformity correction. Got my point? You separate it medially also. Yeah, we cut it like, look that, just I cut it like this, okay, and then I rotate it and again fix it. That is the paradoxically lateral crura deformity correction, lateral crura flip technique. Okay. So regarding the size, by the cephalic trimming, regarding the SEP, by the lateral crura flip. But sometimes what happened, some patients, they don't have the diffuse lateral crura SEP deformity, they have some partially. Suppose the small part of this one have the concavity. So when a patient have a partially paradoxically lateral crura deformity, then there is no need to flip the entire lateral crus. Just you make a simple pocket and you put the small graft under surface. That is the lateral crura underlay graft. Support के लिए small graft. Because unnecessary, when you correct the abnormal anatomy, you never disturb the normal anatomy. This is the important rule. Okay. So you judge that your patient that have a partially or have a diffuse paradoxically lateral crura deformity. Okay. Now after the size, shape, The next deformity of this lateral crus is the orientation. For orientation, look at what orientation? Look at this picture of the patient. I show you. This is the lateral crus. अरे उनको ऑडियोविजुअल वालों को बुलाना. This is the lateral crus. This is lateral crus. Look, this is the ideal. This is the ideal orientation towards the lateral canthus. But sometimes the things are changed. When this orientation is towards the medial canthus, then the patient develop like this. Like this. This is the cephalic malposition of the lateral crus. Ideally, the angle of lateral crus is more than 35, around the 45 degree. Around the 45 degree, okay? If less than 35 degree, then the patient develops the cephalic. Then what happened? Because when the patient have the cephalic malposition, then the patient lost the support of this ala rim, because this part gives support to the anterior part of the ala rim. So the patient develop a deformity that we call the parenthesis deformity. Okay? That we call the parenthesis deformity. Parenthesis deformity. So in parenthesis deformity, just there is a bulging in, and the patient develops some external nasal wall insufficiency also. ये बताना एक बार, ठीक है ना? So this is the basically the cephalic malposition of the lateral crus and the parenthesis deformity. Look at this. You understand this one, because this is the around the almost the 45 degree angle. Okay, and this is the around the less than 45 angle. So the patient develop this deformity. Okay. Now how you correct it? Now for correction of this one, look that we want to reposition in new position, new orientation. So when we correct something in the new position, then we need the some graft, okay, for fixation of the छोटा मेरे को ग्राफ्ट देना, छोटे ये दे दे, कोई दिक्कत नहीं, सीजर देना. So for fixation in the new position, like we need a graft for fixation of this structure in new position. Now how can we use the graft? Either we graft use the in this way, or either the in this way. Okay, if this graft you fix like in this way, then this is the lateral crura stud graft. That means if you fix your graft on under surface of the needle pass करना, नहीं पकड़ के, ऐसे नहीं पकड़ के, थक थोड़ी गया तू, पकड़ के पास करो, हाँ ढंग से. If you fix your graft on under surface of the distal part of the lateral crus, because I cut it, so this is the free, so this is the lateral crura stud graft. Okay, if I put it on under surface of the distal end of the lateral crus, that is the ala batten graft. I personally feel that between the lateral crura stud and ala batten graft, this lateral crura stud graft is better, because this end of the cartilage that have the pushing effect on upside. But if I use this on upside, then have the push on the downside. So the tension effect of this part, that is the good for the patient. So this is the lateral crura stud graft for the orientation deformity of the lateral crus. Okay, so we fix it by the graft, by the suture, 2 or 3 suture, and this part where we fix it, this part we fix it on outside of the pyriform aperture, just on the pyriform aperture, just to make a सीजर देना. इसको एक सूचर लगा दो एक बार, because this part we separate, so this is the unstable. इसको पकड़ो ऐसे, so just we create the space here on this side in the new orientation. Look that my direction of the seizure is towards the lateral canthus. Okay, towards the lateral canthus. So just on outside of the pyriform, not inside. This is the important thing. outside of the piriform aperture. So this part we put inside of this, just like this, and we suture it. So we just put in the new orientations. So this is the lateral crura stud graft. Okay, you clear? Now sometimes when patient have problem regarding the strength of this, when you have a weak lateral crus, then one is just you make a incision, just like you make a incision. Okay, just Mukesh pakadna. Just you make a incision, you separate it, and then you just make a pocket on this under surface and move on underside. That is the lateral crura turnover. You understand? That means we just create like this. Yeah, and इधर से भी इसको separate किया. So just like this one, we separate scissor देना. We not complete separate, just make incision and then rotate it on under surface of this one. So we just turn over after create a pocket on this rest of the cartilage on this. So we just like fold it. So this is the lateral crura turnover. So these are the basically deformities regarding the lateral crus or lateral limb of the Anderson. Sometimes the patient some have regarding the SEP, usually we use some words like my patient have the broad tip and the bulbous tip and the boxy tip. So this is also clear in your mind. Then if your patient have a distance more than as usual like the 6 to 8 or 8 to 10, that is a broad tip. Okay, if the patient have a distance, that is the broad tip. Okay, and what is the boxy tip? Then look at this dome, they have a angle between like this. If ideally the angle of the dome divergence is the 30 degree. If you have the more than this, then you have a boxy tip. You got my point? If you have an angle of dome divergence that is the more than 30 degree, then you have a boxy tip. And what is the bulbous tip? Bulbous tip is basically when you have an index more than 0.6 between the tip width oblique the ala base width. The distance between this tip width and this ala base width, the ratio is more than 0.6, that is the bulbous tip. Give me the dinwa, apne paas hoga ye. Yeah, look that. This is the normal tip. Okay, the angle of dome divergence, unko bulana Deepak ji ko. Angle of dome divergence. This is the dome and ideally the 30 degree angle. Okay, this is the 30 degree angle. Look that when a patient have more than this is the boxy tip. So when we use in the routine practice, then we know what exactly meaning of this one. What is the boxy tip? What is the bulbous tip? And look that this is the bulbous tip. So in the bulbous tip, the ratio between this one and ratio between this one is more than 0.6. Then we use the bulbous tip. This is the boxy tip, and this is the bulbous tip. Okay, so this is almost all about like our all steps, and like the first we discuss about the infiltration, and then the exposure, and then the septal modification, then the bony pyramid modification by the different combo of the osteotomy, then MIDVAULT modifications by the spreader graft and the spreader flaps, and then by the tip modifications, and then last is the closing. I usually use for the closing the 5 tip suture techniques, but in this patient, because now we separate the skin, it's very difficult to demonstrate. Tomorrow when we go on the live session, then we discuss. A last basically deformity that is very rare, but it's very confusing regarding the LABS modifications. So LABS modifications, we just discussed the brief about the LABS modification is also like the, but what you asking something? Lateral crural stele. Yeah, lateral crural stele is what is that? Then suppose this is your lateral crus. Okay, this is your dome. Okay, so we separate this part and we create a new dome, just like we separate this lateral crus from the underlying the vestibular skin, and then we create a new dome. We just steal some part of the lateral crus just for getting more definition. This is one of a method for the projections, lateral crural stele. That in a cleft lip nose cases usually we need lateral crural stele. Okay, when in the live case usually I demonstrate. So this is the lateral crural stele. Regarding the basically the LABS excision, usually we try to avoid the LABS excision. There is a two reason why we avoid the LABS excision. One is the scar concern for the patient, and the second is the lack of the anatomy, lack of the confidence, because we also afraid about the. So there is a rule: if you bias, if you confuse regarding the LABS surgery, you don't do it, because sometimes regarding the your patient asks to you, I need the LABS excision, and your patient tip have the under projected tip, and after the projections the automatically the LA flaring or something. So you have to know the comprehensive knowledge regarding the pre and the post. Okay, then you explain to the patient, because if you once you excise, then it's very difficult to reconstruct. Okay, so you also know the morphology regarding this LA lobule. Then your patient need the either the LA base excision or LA seal excision. So look that if the distance between these LA facial junction, okay, the distance between the LA facial junction is equal to the intercanthal distance. This is a rule. Okay, inter-LR width, that is the equal to the intercanthal distance. Okay, if you have the more than, because this is the LA margin, this is the LA base. Okay, if you have the excessive concavity of this part, that we call the LA flaring. That we have the LA flaring. Okay, and if you have the excessive width of this one nostril, between the nostril, that you have the excessive inter-LR width. Okay, so if your patient basically have this normal inter-LR width, first you know that if you want to correct this LA flaring, then you excise this LA base part. Okay, but if you want to reduce this width, then you excise this sill part, nasal sill part. Okay, so first you decide that what is your patient have a excessive LR flaring, or if your patient have a excessive LR width. Okay, if your patient have this excessive LR concavity flaring, then you reduce, you excise this some base part of this LR base excision. How much you excise, that is the important thing. How you decide, you measure between the inter-LR width, and then basically you just mark a line from this medial canthus and how much amount you have the flaring, then we just excise the incremental manner. So if we have patient, then we just demonstrate. So it's important, then your patient have a excessive LR flaring or excessive LR width. Okay, so I think this is all about regarding all steps of the rhinoplasty, and if you have any more query regarding this, then definitely you first you just finish your lunch, and then you can feel the nose, and then we discuss more. I think this is all about, because more than this Nothing.
Yeah,
Sir.
Dr. Sunil, I measured a few things.
Sir,
Just show them the LR reduction process.
So you want to show that LR reduction because Dr. Kapil have a very good technique of the LR reduction technique. So basically just I show you the simple procedure for LR base reduction. Suppose if your patient, the marker dena. Boss, I want to learn your technique from you. You have a different technique, but I show you for my participants the simple technique for LR base excision. Basically, suppose if you want to, if you have a excessive LR flaring, okay, then if you want to this excise this LR base, then first you mark. So your marking that I usually mark just few millimeter above this LR facial junctions. I think Dr. Kapil not agree with this one. They use the lower marking on this LR facial groove, but I usually just mark just little bit out few mm above this LR facial junction. Okay, and then the upper just you according to your need you mark on the right side just around the 8 o'clock, on the left side lateral extension around the 4 o'clock, and then you just make an incision till the at the just subcutaneous tissues, and we excise it, and then just you use as a template. If the patient, I mean both sides, then you just mark on this side, and then we excise. Dr. Kapil boss, you want to add something because your technique is very good. Something
that is slightly different from this.
Yeah, that is slightly different. So this is basically LR base. But suppose if you have this excessive seal, this posterior cylindric alias seal, then you want the wedge excision of this part. So just you mark like this, and then you mark like this, because this is the free skin. Then you excise this part. Just you reduce this inter-LR width. Just you reduce this part, we excise this part, and then we narrow the nasal cavity, reduce the inter-LR width. Skin and subcutaneous. Ideally till the mid muscle level. Boss, what is exact the depth of LR base excision?
Only skin from outside, nothing else.
Only skin.
Yes.
Yes. So
in that way you are not actually cutting the blood supply, as well as you are not releasing the forces which are responsible for the convexity of the LR.
Yes, perfect.
And you are not going inside the nasal floor.
Yes. Yes.
The excision is restricted up to the seal only.
Yes. Exactly. Yes. So these are some techniques, and just the 7G steps, 7 golden steps. So in the next 6 days we repeat all these. So repetition is the key of our course. We again repeat the same thing. So, and there is a lot of techniques, but you just first learn the basic techniques, primary cases, simple cases. So you build up your confidence. So I think we just wind up, boss, and thank you for the joining. Give your precious time. I think Sandeep Pon sir.
I'm here.
Oh, sir, great.
Sorry, I was stepping in and out. I'm also I've got one eye also on the cricket, as you know, India are playing today.
Sir, so we just I try to just all basic techniques for my participants. And
no, you've done a fantastic job, and it's as I always say to you, it's wonderful seeing how much you've learned, hopefully over the years with me being there with you. But you are now doing the steps in pretty much exactly the same way as I do, and it's great to watch. So congratulations! I'm sure the participants will have a wonderful few days with you in Jaipur, and hopefully we'll be meeting in Kolkata soon as well, in about a month's time. I'm looking forward to that as well. So my best wishes to everyone who's there. Pradeep, I don't know if Pradeep is still there. It'll be good to see you again soon, and Same with you, Kapil. It's been a long time. Let's try and catch up soon.
Yes, yes.
Dr. Kapil.
Very good job, Dr. Sunil.
Thank you both. Thank you.
Explained everything in the fine detail actually.
Thank you. Thank you, Dr. Kapil, Dr. Sandeep.
Person who
Thank you very much.
New to the rhinoplasty can learn everything today. Should have learned. And I'm sure that the participants as well as all delegates who are on the screen right now, they might have learned
Dr.
nuances.
Sandeep, your face looking quite glowing. What's the reason?
I don't know.
Yeah.
Me, I don't know. Maybe it's because India just got a second wicket.
Yeah.
Or drinking a lot of wine.
No wine. I'm just. It's early morning here. It's too early for any wine.
So nice to see you after a long time. Thank you.
Yeah, absolutely. No, I'm just. It's early morning. We're watching the cricket as well as watching Sunil operate. So it's great. Sunil, your headlight even makes you look like me now.
Yeah. I bought this one, sir, because now I need some magnification. So this one is good.
Yes, yeah. It shows you're getting a little older now, which is good.
Good.
Okay, well, send my regards to Sushila. Send my regards to Mukesh.
Today she is in Delhi for some surgical demonstrations. Evening she will come.
Yeah.
So otherwise, definitely she.
Pass my regards to the staff, and Mukesh, you did a great job in assisting you as well.
Yeah, thank you, sir. Thank you. And again.
Okay,
sir. Soon we'll meet in the Kolkata next month.
Absolutely, we'll meet in Kolkata. Yeah. All right. Take care.
Okay.
Bye.
Bye, Sunil. Bye.
Thank you, Kapil. Thank you, Dr. Hakim.